Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon for everybody. And this is Dr. Najib Jani will coordinate for the 7th endocrine review course instead of Dr. Nasr Jani. He apologized as we traveled outside KSA. Today we will have our first presenter, Dr. Muhammad Bashir. We have today 3 days of comprehensive endocrine review course. The first day will be type 2 diabetes, thyroid, and adrenal. The second day, there is a little bit swap. We have pituitary, male reproductive, and lipid, obesity, and type 1 diabetes. And the third day will be female reproductive, calcium parathyroid, and obesity. Let us, and we would like to appreciate all the interest of the speaker, eminent speaker, as well as chairman of for this course. Our first presenter, Dr. Muhammad Bashir, he's a PhD consultant in endocrinology in South Tipperary General Hospital and Permont Hospital, Ireland. There is 1 hour and 15 minutes for each presentation, and there will be 15 minutes for Q&A. For any participant, if you have any question or any thing you want to add, you can put it in question and answer, and we will discuss this after the session. CME hours will be accredited after 3 weeks. This will be sent to you by email through Dubai Health Authority. Welcome, Dr. Muhammad, and we can start.
So, Assalamu alaikum, Dr. Najib. Just confirm that you can see my slides, please.
Yes.
Great. So thank you very much for the kind introduction, and thank you very much for the invitation. So I'm going to be discussing the type 2 diabetes review today. And just before I go any further, because the type 2 diabetes management has a lot of controversies and a lot of differences in practice. So in exams or in any form of formal assessment, the decision should be on the best possible answer based on guidelines and based on evidence and just not based on the current practice. So these are my disclosures. Are we discussing multiple medications? So the first question is regarding a 60 years old Arab gentleman with a type 2 diabetes for about 24 years. He's known to have CKD stage 3A, no previous history of cardiovascular disease. He's known to have hypertension and dyslipidemia and diabetic retinopathy. And he's taking Glargine U100, 30 units at bedtime, and insulin aspart, 30 units 3 times a day. This gentleman had a road traffic accident while driving back from Friday prayer and was unconscious, and his and the ambulance confirmed that he was hypoglycemic at that time. Fortunately enough, he's unhurt. He doesn't monitor his blood glucose regularly, however, did describe some hypoglycemic unawareness. His HbA1c was 7.9%. His EGFR was 45 mils per minute. The rest of his blood tests were normal, and his BMI was 30. So what is the best next step in this gentleman management? Are we going to reduce all the insulin doses by 20%? Or we're going to switch to insulin degludec or Glargine U300, ultra-long basal insulins, add metformin and reduce insulin doses? Are you going to add empagliflozin and reduce insulin doses? Or are you going to add both dulaglutide and dapagliflozin and reduce insulin doses? So you can vote now. Okay, so we have majority of the group said that we need to reduce our insulin by 20%. That was followed by add empagliflozin and reduce insulin doses, which is that 6%, and about 16% said we go with dulaglutide and empagliflozin. So the correct answer here is actually to add the dulaglutide and dapagliflozin and reduce insulin doses. And the reason here for all these drastic changes is very simple. This patient have multiple issues happening right now. In addition to the fact that he has severe hypoglycemia, this gentleman is at high risk of cardiorenal disease. So he's 68, he's male, long duration of diabetes, already have evidence of CKD. However, this gentleman never had a previous history of cardiovascular disease per se. So in addition to reducing his risk of hypoglycemia, he has other things to look at as well, and he can manage the two at the same time. So basically, dulaglutide, when it's combined with insulin, was shown to have reduced insulin-sparing effect. And when you combine them together, you probably reduce the insulin doses by about 21% of the basal insulin dose. And as well, in practice, you can reduce drastically the bolus insulin doses. And that per se will reduce the burden of hypoglycemia in this gentleman. However, what's more critical than that is that dulaglutide has an impact on cardiovascular disease. And that was based on the REWIND trial that looked at dulaglutide versus placebo and looked at the 3-point MACE as primary outcome. But what's different in this trial is that they recruited the majority of the patients were at risk of cardiovascular disease. So they did not have cardiovascular disease. And this was a superiority trial. So they're trying to show that dulaglutide is better rather than the usual non-inferiority trial. So the majority of those patients were in the primary prevention arm rather than secondary prevention arm. And what they did show in the REWIND trial that there was a reduction in the 3-point MACE by about 12%, mostly driven by reduction in non-fatal stroke. More critical is when they do a form which is known as sensitivity analysis to see what group of patients might not benefit from the intervention. They found that regardless of whether the patient was in the primary prevention arm or the secondary prevention arm, dulaglutide still works in this group of patients. So this gentleman did not have cardiovascular disease per se, and he will fit in the high risk group, and he will benefit from adding dulaglutide as primary prevention. Now, dapagliflozin was tested in patient with chronic kidney disease in a study known as DAPA-CKD. And in this study, they recruited patients who have high urine albumin-creatinine ratio with a reduced eGFR. And their main outcome was looking at renal outcome. And 50% of those patients had diabetes, and the other 50% did not have diabetes. And before we go any further, because diabetic kidney disease is very common nowadays in exams, you need to understand a very important relationship when you're looking at these studies particularly as well. That the higher the urine albumin-creatinine ratio, the higher are the rate of progression of chronic kidney disease, and the higher are the rate to progress to end-stage renal disease. And a very important relationship is that the rate of decline in eGFR, an annual decline in eGFR, is higher in those patients with a high urine albumin-creatinine ratio. So in any of these studies relating kidney disease, it's very important to understand where your patient fits in this graph or in this heated table, because the more albumin-creatinine ratio they have, the more they're going to progress. And the DAPA-CKD had a very high risk group of patients enrolled in the study. And what they did show is that there was a protection or a delay in the onset or protection against progression in kidney disease among patients taking dapagliflozin. What's critical in this study is what is known as the eGFR slope, which is now becoming a genuine kind of outcome to report in kidney disease and to monitor as well. And the eGFR slope basically measures the annual changes in GFR. And what happens in these studies, as you would expect, that those patients have a high urine albumin-creatinine ratio, they're going to decline very, very quickly, as you can see in the placebo arm. In the dapagliflozin arm, there is an initial decline that happens very early on, but there was a reduction in the eGFR slope. And that means that these medications reduces the decline in eGFR, and hence they reduce the progression of kidney disease. And this happened regardless of the patient had diabetes or did not have diabetes. And that's the second reason why dapagliflozin should be added to this patient. It probably would provide him nothing. It would not provide anything in terms of protection or in terms of insulin sparing effect and insulin doses. Will you reduce our insulin doses by 20%? Yes, that will sort out a problem of severe hypoglycemia. However, based on what we know about insulin in multiple trials, insulin is neutral. It doesn't increase the risk of cardiovascular disease and does not provide protection against cardiovascular disease per se. Will you switch to long-acting, ultra-long-acting insulin? So the longest trial we have was compared insulin degludec with glargine U100, is known as the DEVOTE trial. All those patients were treated to target. And one of the multiple secondary outcomes were the lower rate of severe hypoglycemia among patients in the degludec arm. Glargine U300, the definition of hypoglycemia was a little bit different from other studies, but there is a hint or a suggestion that this ultra-long-acting insulin might have a lower rate of severe hypoglycemia. And hence, switching around insulin per se can reduce the chances of hypoglycemia. However, as I said, it does not treat the whole situation of this gentleman. Now, will you add metformin and reduce insulin doses? Will metformin have any insulin-sparing effect? And this is one of the meta-analyses that looked at that, and it did show that, well, adding metformin on patient on insulin or keeping metformin on patient on insulin provide you with better glycemic control, lower HbA1c, and have a favorable metabolic outcomes. You have an insulin-sparing effect, and you have an insulin-less weight gain per se. But again, the impact on the rest of the risk factors will be minimal. Now, the part which I just mentioned over to you is add dapagliflozin alone and reduce insulin doses. SGLT2 inhibitors activity are all depending on how much glucose is filtered in the urine, and that is completely dependent on the eGFR. And the lower the eGFR, the lower is going to be the impact or the effect of SGLT2 inhibitors on glucose. And eGFR less than 45, these agents have almost no effect on glycemia. Generally speaking, SGLT2 inhibitors, when added the insulin sparing effect of them is modest. It is there, but it is modest. But in this patient particularly, it's probably not going to work and not going to help in reducing insulin doses. So we'll move on to the second question now. This is a 58 years old woman, have a 4-year history of type 2 diabetes, hypertension, and dyslipidemia. And she came over to you because she's concerned about her cardiovascular health. She's taking metformin 1 gram twice a day, ramipril, and she's simvastatin 20 milligrams per day. No previous history of cardiovascular disease. However, she does have a family history of premature death and premature myocardial infarction in multiple relatives that happen under the age of 50. Smokes about 10 cigarettes a day for about 10 years with failure attempts to quit. Physical examination showed a normal blood pressure. She was obese with a BMI of 30. Her HbA1c was 7.2. The rest of her bloods were normal. Her LDL was 3.1. HDL was 1.67. And triglyceride was 1.64. So which of the following medications is most likely to lead to significant lower rates of vascular event in this patient? Remember, she never had a cardiovascular disease before. So it's a primary prevention. So are you going to give aspirin 100 milligrams per day? Or are you going to give empagliflozin 25 milligrams per day? Or lexazenitide, lexazenitide, rosuvastatin, or sitagliptin? So you can vote now. Okay, so what I have here is the 64% voted for rosuvastatin 20 milligrams, 16% selected empagliflozin, and about 13% went for aspirin. So what is the correct answer? So the majority of you are correct. So the answer here is to use rosuvastatin 20 milligrams once per day. So, and the reason for that is that rosuvastatin or statins in general are instrumental and they are pivotal in reducing the risk of cardiovascular disease as a primary prevention in high-risk patients and in patients with diabetes as well. And it does reduce major coronary events and it does reduce mortality as well. However, what's critical when you look in selecting the statins therapy based on the most recent ADA guidelines is that you need to run what is known as the 10-year cardiovascular risk score. And I just calculated at the top here, her 10 years cardiovascular risk score, which is about 12.8%. And anything above 10% is quite high. And based on her risk factors and her family history, she requires what's known as a high-intensity statins. And that is being defined as atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. The rest of the doses and agents are considered moderate intensity. And the high intensity reduces the LDL by 50%. And as you're aware from epidemiological studies, the lower the LDL, the lower are the incidence of cardiovascular disease. Now, will you use aspirin 100 milligrams? About 13% of you said yes. So the ASCEND study, you looked at patients with as a primary use of aspirin as a primary prevention in patients or people who have diabetes. And what it did show that these agents do work. So if you look at the top, if you look at the into this table, you will find that these agents overall reduces the risk of cardiovascular disease by about 12%. However, the risk of major bleeding is increased by 29%. So if you do the number needed to treat in these agents, you will find that you need to treat 91 patients in order to prevent one event. However, you will need, with every 111 patients, you'll have a serious major bleeding. And hence, the risk-benefit ratio is against the use of aspirin as primary prevention. And the recent guidelines by the ADA will actually say that you don't offer it. You may consider it after discussing with the patient and after taking into account what is the risk of bleeding in those patients. Now, when you use empagliflozin at 25 milligrams a day, and that was selected by 16% of you, and SGLT2 inhibitors in general, when they've been looked at meta-analysis and when they performed sensitivity analysis, there was a very clear lack of efficacy as a primary prevention effect. In other words, in those who never had a cardiovascular disease before, these agents don't seem to provide cardiovascular benefits. However, in the future, we might find something different, but most of these studies did not enroll enough numbers of patients with no history of cardiovascular disease, apart from one study. However, as it stands right now, empagliflozin or any of the SGLT2 inhibitors do not have a primary prevention effect. Lexazenitide was studied in a trial known as ELEXA, and it was shown that it does not increase or reduce cardiovascular disease. Same as sitagliptin in the TECOS trial, and it was neutral. So all of these agents are cardiovascularly safe, but they do not add any cardiovascular benefits per se. Okay, so we're coming to the third question now. You have a 55 years old patient with a long-standing type 2 diabetes, is insulin, and she came over to you because she's concerned that her new glucometer device is not accurate. She's been forced to change the glucometer based on the insurance company policies. You looked at the results between the new meters and you compared it with your hospital point of care using blood tests from the same finger prick. The hospital reading was 142 milligrams per deciliter, 7.9 millimoles per liter, while the glucometer was running 159 milligrams per deciliter, which was 8.8 millimoles per liter. Well, obviously, this patient who is insulin treated is concerned because she depends on the glucometer's readings on her insulin adjustments. So what you're going to tell this lady? So which of the following is the best recommendation for her? Calibrate the new glucose meter, or compare the results with a lab results rather than with a point of care capillary blood test. Keep the meter the same and reassure her that her meter is okay, or switch her to her old glucose meter, which she was happy with in the past. Okay, so there's a split here. Half of you said keep the same meter. Half of about 29% said calibrate the new meter, and the other said compare it with the lab, compare the results with the lab. 16% said compare the results with the lab. And this is an actual case that I found in the most recent endocrine society cases, and the answer here is yes. Half of you found out that you need to keep the new meter the same because the discrepancy is within the acceptable range. And I found that this is a very important topic to bring and important things to pay attention to, because the glucometers that is used on a daily basis are actually regulated by certain by guidelines published by the FDA that we are not, most of us, not aware of it. And this, talking about home glucose monitor, they have to fulfill certain criteria. So what this document say that any home glucose monitor should look at 5 different ranges of glucose, from as low as 30 milligrams per deciliter to as high as 400 milligrams per deciliter. And each of these 5 levels, there is a acceptable margin of error. So what they said is 95%, should be within plus or minus 15%, and 99% should be plus or minus 20%. In other words, if you have a very well controlled patient and the glucometer reading is saying it's 100 milligrams per deciliter, so the actual reading is anything between 80 milligrams per deciliter to 120 milligrams per deciliter. And that is within the acceptable margin of error of the FDA. And in this lady, the difference between these glucometers are within the acceptable margin of error of the FDA, and hence you cannot probably justify changing the meter. Most critical of this is the guidelines on hypoglycemia, because it's very hard to get patients in a glucose level between 30 to 50 in order to compare the accuracy. So every glucometer should tell you what is the lowest limit they should be able to manage, and it has to be something around 50. So anything that they have to be able to do something even around 50 milligrams per deciliter. But any glucometer should tell you what's the lowest and the maximum I can touch. However, this is the correct answer, but in practice, very important things to understand is that the difference in the glucometer between the readings are actually assessed in a different way, which is different of zones. So zone A, when you compare a glucometer with a venous sample or a different glucometer, if it's running within zone A, it does not impact your clinical decision. These small changes are not going to make you increase or reduce the insulin doses. Zone B, it's very unlikely that happened, and A and B are considered within the safe zones. However, if you have a lot of readings running into zone C, that will impact your clinical decision, will get you to either wrongly increase or reduce the insulin doses. And that has clinical significance. So in clinical practice, when you're comparing them, you have to take into account how tighter you want your patients to be controlled and how much error you're able to tolerate within these meters when you're switching around between different meters. All right, so question number 4. This is a 34-year-old gentleman who was newly diagnosed with type 2 diabetes during a routine screening process. He has no symptoms of hyperglycemia, not a smoker, accountant, doesn't exercise. His weight has always been choppy, and over the last 2 years, he's gained 4 kilograms. Strong family history of type 2 diabetes, both parents and one sibling. Clinical examination, blood pressure was normal. His BMI was 32, and apart from that, examination was unremarkable. His HbA1c was 8.7%. eGFR, liver function, everything else was normal. LDL was 3.4, HDL 0.9, and triglyceride 1.9. So what's the next step in managing this gentleman type 2 diabetes? You send him for lifestyle changes and review him in 3 months' time. Aim for weight loss and more exercise. Start him on metformin. Start on a combination of metformin and vildagliptin. Start this gentleman on sitagliptin, or start this gentleman on gliclazide MR. You may vote, please. Okay, again, a split vote. So about 48% said start on combination therapy. About a third said we go on metformin, and about a quarter said just lifestyle changes and see this gentleman in 3 months' time. So what should we do here? So the correct answer is start on combination therapy in this gentleman. So the reason for that comes from the evidence comes from a study known as the VERIFY trial. And the VERIFY trial looked at patients newly diagnosed with type 2 diabetes, medication naive. And they did randomize them into 2 arms. The first arm, they gave them dual agent, metformin at a maximum dose, 1 gram twice per day, and vildagliptin as well, a combination therapy. And the other arm, they gave them metformin, 1 gram twice per day. If they failed on the metformin, which the definition of failure is a HbA1c of 7% on 2 consecutive readings that are 3 months apart, then they will add vildagliptin. And the primary outcome in first period is the time to failure, how durable these medications are. So what's the proportion of patients requiring intensification? And the second period as well, after patients fail on metformin alone, when they add vildagliptin, how long does this take them compared to those patients taking the 2 agents together? And what they did show is that the median time to failure on a monotherapy on metformin was about 36 months. And you think about it, it's about 3 years. It's not bad. However, in those patients with vildagliptin, it's taken them a little bit longer to fail. So the study ran for 60 months, and they still did not cross the median time yet at that point in time. So the hazard ratio of failure was about 49%. So you have a 49% less chance to fail within 5 years. This patient have a 49% less chance to fail and require any other agent within the first 5 years of treatment. Now, what they did is, so the second part here is the second period. When you add vildagliptin to metformin, will it make any difference? And what they showed, even when you add vildagliptin to metformin, the failure rate in this arm is still higher than those who use the two agents together. So the sequential therapy, the failure rate is much higher, and they're less likely to treat once compared to when you add a dual agent. So this has a sensitivity analysis as well that showed that these factors were independent of HbA1c and independent of renal function and gender. The more critical part of this trial is that they did a sensitivity analysis or a subgroup analysis where they looked at patients under the age of 40 and above the age of 40. And as you know, early onset type 2 diabetes have a faster progression of that diabetes. They have an accelerated beta cell loss, and they're more likely to require intensification of treatment. And what they did show in this study is that the dual agent did work in patients above the age of 40 or under the age of 40. So it will still provide durability. So what the current guidelines tell us is that when you're looking at patients with diabetes, first time to meet them, do they have established cardiovascular disease or any of that? You start on empagliflozin or SGLT2 inhibitors or GLP-1. If they don't have the risk factor, then there are multiple other options. More critical here, that the ADA currently recommends that to start dual agents in those patients with a HbA1c who are higher than 8.5%. And also in young people with type 2 diabetes. So this gentleman is young. Anybody younger than me is young. He's 32 years of age, and his HbA1c is above 8.5%. That was the ADA says. What the ACE says, and they're more aggressive in their treatment, is that if the HbA1c is above 7.5%, then you need to start a dual agent. But the ADA is modest and using the 8.5%. So this gentleman fulfills this criteria. Now, will you start gliclazide MR in those patients? And an old study, which was a landmark trial, known the ADOPT study, looked at the time of failure in TZDs, metformin, and sulfonylureas, and sulfonylureas fail quicker than any of the other agents, and they will require intensifications, and that's why they moved away from being a ferrous agent therapy. Okay, now question number 5. There's a 29 years old man with type 2 diabetes for 12 years and came for clinical review. He had an MI 4 years ago and has been on metformin, glargine 28 units, Lespro 12 units with his lunch and dinner twice a day, lisinopril 20 milligrams, atorvastatin 40 milligrams, and taking aspirin 75 milligrams once per day. His HbA1c has been running between 7.8 to 8.5%. He's a former smoker. He does exercise 2 to 3 times a week. His weight has been between 85 to 88 kilograms, and his fasting blood glucose between 7.5 to 8, and pre-meals were a little bit higher, 11 to 12 millimoles per liter. Clinically, blood pressure was normal, BMI was 30, his HbA1c was 8.5%, his EGFR was 84 mils per minute, liver function, urine albumin creatinine ratio was 20, and LDL cholesterol was 1.9 millimoles per liter. So what is your next step? Well, he's already in insulin, HbA1c is higher. Are you going to increase the glargine by 20%? Are you going to add canagliflozin 100 milligrams once per day? Are you going to add Lespro with breakfast? Are you going to reduce glargine by 20% and then add dapagliflozin? Or are you going to reduce Lespro by 20% and then add dapagliflozin 10 milligrams once per day? And you may vote, please. Okay, again, a split vote. So less than half said you add canagliflozin 100 milligrams. 29% said add DAPA and reduce insulin glargine by 20%. About 20% said add dapagliflozin and reduce Lespro. And very few said we have to increase the glargine by 20%. Now, so where are we with this gentleman? So it is actually canagliflozin 100 milligrams once per day. And this gentleman did have a myocardial infarction, and he's only on blood glucose are above target, and he's only on insulin. So the Credence trial, or sorry, the Canvas study compared in patients who already have cardiovascular disease, compared the use of canagliflozin versus placebo. And in this trial, the majority of them, about 3/4 of them, did have established cardiovascular disease. And what it did show that when you use canagliflozin in this type of patients, that you reduce the 3-point MACE. So there is a protection against cardiovascular disease by about 14%. However, the empagliflozin, or the declared TIMI trial, was a similar design in looking at prevention of the 3-point MACE. However, in this study, they recruited less than 40% of the or about 40% of the patient have established cardiovascular disease. So they were looking at primarily a large group who are looking for primary prevention rather than secondary prevention of cardiovascular disease. But this study had two primary outcomes, but within this setting, the 3-point MACE in those group of patients did not differ at that study. Subgroup analysis later on showed that, well, in those who have cardiovascular disease, it worked. In those who didn't, it didn't work. But the 3-point MACE was negative in this group. But the impact on heart failure, as you're all aware, are actually being maintained. Now, and this is just showing that the EMPA-REG, which used empagliflozin study, all of them have cardiovascular disease, and all of them were a very high risk population compared to what the declared TIMI was, which was a lower risk population in this trial. Now, are you going to reduce glargine by 20% or reduce Lespro by 20% and then add dapagliflozin? This is something that you need to do with cautious, because as I said, the insulin sparing effect of dapagliflozin or SGLT2 inhibitors depends on the renal function basically, but it's very modest. And the worry normally, if you did multiple changes and you suddenly reduce the doses of insulin and you start add dapagliflozin, that you might push those patients towards euglycemic diabetic ketoacidosis, has been reported in few case series. So you be very cautious with this choice, and has to be this euglycemic DKA should be taken into account. Now, are you gonna add Lespro with breakfast? So the patient is already taking 2 injections of Lespro. Are you going to add another agent at this point in time? And as I recall here, I told you his fasting is normal, his pre-meals are still high. Now, there are multiple studies that looked at the intensification of insulin therapy. I just selected the study known as the STEPS study, where they take patients, they put them on glargine and enroll them, and to titrate them to achieve a fasting, so HbA1c of 7. In those who did not achieve HbA1c 7, they were randomized into either 1 injection of bolus insulin with 1 meal, 2 meals, or 3 meals immediately. And what the study showed, and this is being consistently shown in multiple studies, is with proper titration of basal insulin, and all of these studies titrated the fasting blood glucose to about 100 milligrams per deciliter, and you get the HbA1c to about 7.9. Now, what's really critical is when you, at this point in time, when you add one agent and you optimize it, you target 1 meal, you bring the HbA1c down by about 0.5%. When you're adding to 2 meals, you have a modest effect. When you add the 3rd meal, you have a very modest effect. So in this gentleman, adding extra Lespro is not going to get us to reach a target. It might actually induce more hypos. It might actually induce more weight gain. But whatever current regime, if you only want to go with insulin, should be optimized, and the fasting should be optimized. The 2 hours, the meal doses should be optimized before adding another 3rd dose, because the benefits are very modest. Okay. Now, question number 6. You have a 25-year-old woman who came for a 3-month follow-up after undergoing Roux-en-Y gastric bypass. Type 2 diabetes at the age of 16, her BMI was 35, when she met you. Before surgery, she was taking glargine 20 milligrams, metformin, and liraglutide. And before surgery, she would she reported her blood glucose used to range. The fasting blood glucose were mostly running higher, and her HbA1c was running higher. Her HbA1c before surgery was 8.5%. After surgery, she went home on glargine 10 units, and she was advised to monitor blood glucose level at home. Metformin and liraglutide was stopped, but 10 milligrams of glargine was continued. 3 months after surgery, she lost 17 kilograms of body weight. She BMI still up, but she lost 17 kilograms. She's fasting glucose is running between 100 to 150 milligrams per deciliter. She continued to go on insulin glargine. Her HbA1c is 6.9%. Now, what we're going to do now? Stop the insulin, glargine. Stop insulin and start semaglutide. Stop insulin and start tirzepatide. Stop insulin and give her empagliflozin. Keep her current regimen unchanged. This is a very split dose here. So about 30% said keep current regimen unchanged. Another 30% said stop insulin. 20% said keep stop insulin and start on semaglutide, and about 50% going with tirzepatide. Okay. So what you need to do here is to stop the insulin glargine. And that comes from the de-intensification of treatment after Roux-en-Y or after any bariatric surgery. And that comes from the STAMPEDE trial. And the STAMPEDE trial randomized patients with diabetes into either intensive therapy, sleeve gastrectomy, or Roux-en-Y. And what they did show, and this is the more critical part here, then HbA1c reduction is very rapid after the operations, and happens as early as 3 months. The drop is more than 2.5%. Notice that those patients are continue to have a reduction in their HbA1c after the 3 months by another 0.5% or so in the future. Now, the drop in the HbA1c precedes the change in weight. So the change in weight in the first 3 months is considered modest. It picks up a little bit later on, but it might take 6 months or 9 months before it plateaus. But the change in HbA1c is quite rapid. And that's why the insulin regimen at that point in time should be stopped. She will continue to improve in the next 3 months, despite the fact that she doesn't seem to have lost a lot of weight. She's going to lose more weight in the future. And this is part of the de-intensification of therapy in those patients post-bariatric surgery. Now, if we excluded this factor here, I said you don't need semaglutide. She will continue to lose weight. She's still not plateaued yet, or any of the other agents. You don't need tirzepatide. You definitely don't need to add empagliflozin for this patient. She will lose more weight based on what we know from the STAMPEDE trial. Okay, question number 7. They have a 48-year-old man who have a history with type 2 diabetes for 10 years, and he presented for follow-up. He's taking metformin and vildagliptin, 1 gram twice per day, taking pioglitazone 30 milligrams per day, and he's taking atorvastatin 20 milligrams per day. Well, this gentleman has been feeling generally well, no specific complaints, and his GP was just concerned about deranged liver function test, which he detected way before the start of statins. He smokes shisha twice per week, doesn't consume any alcohol. Clinically, blood pressure was 134/76. He's obese with a BMI of 32. His HbA1c was 6.9. His eGFR was 90. ALT and AST both were elevated, just above the upper limit of normal. Hemoglobin was 12. Platelet count was 300. His LDL was 2.1. Triglycerides was 1.2, and urine albumin creatinine ratio were normal. So a gentleman with deranged liver function and type 2 diabetes and obesity. What's the next step in his management? So you're going to refer her for liver ultrasound, calculate the FIB-4 score first, refer her for liver biopsy, stop atorvastatin, stop pioglitazone. Please vote. Okay. That's a very interesting vote. So most of you, 74%, said we have to calculate the FIB-4 score first. And about 21% of you are going to send the patient for liver ultrasound scan. very few will stop pioglitazone, and only 1% will stop atorvastatin. And the correct answer here is you're all right. You need to calculate the FIB-4 score. And that was a recent, well, not very recent changes that happened in the guidelines. And the FIB-4 score, you can use a Medicalc online, and that's the link is in the ADA guidelines. You need to log in the age, ALT, AST, and platelet counts, and it gives you a number. So I did the math here for this gentleman, and the score is 1.22 points. But what does this mean? So there are multiple studies that looked at the FIB-4 score for a long period of time, and they're mainly looking at liver fibrosis in patients with non-alcoholic fatty liver disease. And the cut point of 1.30 was found to have a good sensitivity and specificity, or low specificity, but a good sensitivity in predicting in relation to advanced fibrosis. So it was considered a non-invasive method to screen for with a acceptable sensitivity or high sensitivity to look at those patients who might have with liver failure, who might have advanced liver fibrosis. It's been developed in hepatitis patients, and it's been initially, and now it's been enrolled into non-alcoholic fatty liver disease and so on. There are multiple different forms of scores that are available online, but most critical is that the scores, FIB-4 score, when it increases above a certain threshold, and the higher the rate of the FIB-4 score, the higher are the all-cause mortality in patients who have liver disease. So it does predict liver fibrosis, and it does predict high rate of mortality in patients with liver disease. The more critical part of it as well is that it's not only the number on the future, but it's the changes in the FIB-4 score that has been linked to a higher rate of progression or severe form of liver disease. So the higher it goes, the more severe the liver disease is, the lower it comes down, the more benign or less severe the liver disease is. So the changes in the FIB score is very critical as well. Now, what does the guideline tell us at this point in time? And that and these guidelines, this is the ADA guidelines. It did show in the hepatology guidelines a couple of years ago. It made its way to us right now. And the ADA right now recommends that every single patient with type 2 diabetes, regardless of the ALT or AST levels, should have their FIB-4 score calculated at some point in time, at the baseline. And then it categorized them into three groups. The low risk, which is the score less than 1.3 score. You just need to repeat the blood test in 2 to 3 years. You can repeat it 2 to 3 years. If it's an intermediate risk or a high risk, then you need to go to the next step. And the next step is to do a form of scanning or extra liver-related blood test. And based on these results, then you either repeat these tests in 2 to 3 years, or you refer those patients ahead to go for more invasive testing. So this is now in our guidelines to calculate this in every single patient that we see. Now, obviously, I just answered these questions. Liver ultrasound and liver biopsy are not indicated at this late gentleman yet. Now, the thing which I would like to address is that, are you going to stop atorvastatin or are you going to stop pioglitazone? Both of these agents, statins and pioglitazone, have been shown to reduce liver disease or reduce non-alcoholic fatty liver disease in patients with diabetes. So they are actually left on board and sometimes added to these agents. GLP-1 agonists have now been shown to have a positive impact on non-alcoholic fatty liver disease. Now, going forward, if you're doing your exams or especially in the exams, non-alcoholic fatty liver disease has now a new name, from NAFLD to MAFLD, which is metabolic associated fatty liver disease, and NASH has gone to MASH, metabolic dysfunction associated steatohepatitis. So these are the new terminology that's going to show in the literature going forward. Now, 52-year-old woman presented for evaluation of type 2 diabetes, which was diagnosed 20 years ago in a setting of morbid obesity. She does have evidence of non-proliferative diabetic retinopathy in both eyes, and distal polyneuropathy affecting her feet. 8 months ago, she underwent a gastric sleeve procedure and she lost 40 kilograms, and now she's able to cycle about 30 minutes per day. She's currently taking dulaglutide 1.5 milligrams weekly, losartan 25 milligrams daily, and simvastatin 20 milligrams per day. She could not tolerate SGLT2 inhibitors due to recurrent urinary tract infection. Physically, clinically, she's BMI is 32, blood pressure is normal, HbA1c 6.7%, her sodium potassium were normal, her EGFR was 42, her urine albumin creatinine ratio was elevated. So EGFR low, urine albumin creatinine ratio are high, LDL 1.8, HDL 0.93. So what is your next step? Increase the losartan to 50 milligrams per day, add lisinopril 10 milligrams per day, add finerenone 10 milligrams per day, increase dulaglutide to 3 milligrams per day, or add metformin 1 gram twice per day. Please vote. Okay, so about 2/3 of you voted for add finerenone. 20% said we increase losartan, 5% said we add lisinopril, and 4% add metformin, or another group said dulaglutide 3 milligrams. Now, what is the correct answer? Yes, you're correct. Add finerenone 10 milligrams once per day. So what's finerenone? And the new kid in the block. This is a selective mineralocorticoid receptor antagonist, and it has been tested in patients with type 2 diabetes in a study called the Fidelio diabetic kidney disease. And in this study, they took patients with type 2 diabetes who have elevated urine albumin creatinine ratio with reduced EGFR, and the lower EGFR rate was 25 mils per minute. And they did look for primary outcome was composite outcomes in the stage renal disease. And as I told you, in any renal disease, you need to figure out where those patients were, and they were in the most hot zone here, and that means that the high rate of progression to end-stage renal disease. And they did show that the use of finerenone did reduce the composite primary endpoint and did reduce the progression, the composite endpoint per se, mostly driven by a slow in the reduction in EGFR. Now, this EGFR slope, as I told you before, is going to show in many of the studies in the future. And as you can see over here, the finerenone does reduce first of all, there's a rapid decline in this study because of the very high albumin creatinine ratio. And the finerenone seems to slow this slope and seems to reduce the rate of progression the decline in EGFR. What's critical to note here that there is an initial more rapid decline in EGFR compared to placebo that catch up in about 2 years' time, and then the impact of finerenone start to improve to be seen. That's why there is a delay in SGLT2 inhibitors. It takes 1 year before they catch up. In finerenone, it's taking about 2 years before there is a catch up in these agents. And that's why SGLT2 inhibitors are ranking a little bit higher at this stage, but because this lady have recurrent urinary tract infection, this is not an option. They do impact the urine albumin creatinine ratio, however, modestly. They bring them down and they keep them down over the duration of the study. Now, the most recent KDIGO guidelines recommend the use of combination of finerenone with a patient with SGLT2 inhibitors. If you're still having a rapid decline in your EGFR, there have been no studies that combine the two agents together. However, they're recommending their use, or if the patient cannot tolerate the SGLT2 inhibitors, or it's contraindicated for a reason or another. Now, are you going to increase losartan 50 milligrams? You're not going to achieve much. A combination of lisinopril and losartan, which is combination of ACE and ARBs, are of no benefit and currently contraindicated. Now we're going to increase the dulaglutide to 3 milligrams. So the dulaglutide, a exploratory analysis of the REWIND trial, looking at the secondary outcomes. Again, it's exploratory, used a 1.5 milligrams dose, not the 3 milligram dose. And the patients, this was a primarily cardiovascular outcome trials. The patients were in this zone, so lower risk of progression to renal disease. And the outcomes mostly was positive, but again, it's an exploratory analysis. that there was a slow in the decline of EGFR by more than 50%. However, as this EGFR slope is gaining more and more momentum, the same group went ahead and did another analysis to look at the EGFR slope. And as you will imagine, the slope is slower in this group because they're less severe cases. However, even that they're milder cases of kidney disease, it seems that in the CIS exploratory analysis that dulaglutide has an impact here. But it is only the 1.5, not the 3 milligrams. And this is exploratory analysis. It is not a does not provide definitive answer at this point in time. Now, metformin, will you add a 1 gram twice per day for the patient? This is a critical part. You need to pay attention because we've been to and fro from metformin, a love-hate relationship with kidney disease. And there is a study that looked at the pharmacokinetics and pharmacodynamics of metformin. And they found that at EGFRs up to 90, you don't need to adjust doses, you're fine. Lower than that, you might reduce the EGFR dose, but definitely when the EGFR is, the metformin dose, but when the EGFR is less than 45, 1 gram is plenty and is sufficient to provide with the same therapeutic effect of 1 gram twice per day. They went further and tested beyond what the FDA told us when we need to stop, and they found that 500 milligrams a day provide the same therapeutic effect as a dose of 1 gram twice per day. And if you're looking at renal disease right now, in the guidelines, metformin is recommended to be added on or started in those patients in addition to SGLT2 inhibitors, but the dose depend on the EGFR. And EGFR less than 45, you need to start 1 gram once a day only, or lower doses. EGFR upper than that, you can aim for higher doses and monitor the EGFR and adjust the medications accordingly. So in the previous patient, 1 gram twice per day is a big dose in this gentleman, in this lady. It could be used, could be added, but should be 1 gram once per day. Now, a 57-year-old woman had primary polycythemia, presented for the management of type 2 diabetes. She has had, which she had for about 16 years. She's currently taking metformin 1 gram twice per day, insulin degludec 20 units per day. Her HbA1c is 6.7%, no signs or symptoms of hypoglycemia. She is a professional violinist. And while she's having a decline in her, and she kept refusing to do glucose monitoring because she doesn't want to impact her sensitivity and finger stick herself. Now, you recommended a professional continuous glucose monitoring, and she came with these results. I'm gonna leave it for a moment. And these are the indices, and here is the graph of this lady, the ambulatory glucose profile graph. And the question here is very simple. What you're going to do next? She's meeting targets. Leave her alone. You need to reduce the degludec dose by 20%. Reduce the degludec by 20% and start aspart with lunch. Reduce degludec by 20% and add lexazenitide. Increase degludec by 10%. Okay, so there's a split vote here. So 20% said reduce the, 42% said we reduce the degludec. About a third said reduce the degludec and add aspart with lunch. And about 14% said reduce degludec by 20% and add lexazenitide with lunch. So based on what we see here, what you need to do is reduce degludec. So I'm gonna go back here and look at the graph, sorry. So this patient is having high rate of hypoglycemia with a very high rate of severe hypoglycemia. And you can see in this profile that the hypoglycemia profile is carrying all the way at nighttime. I understand why people are saying you add glargine with lunch, but this lady has a lot of hypoglycemia happening at nighttime. Now, the current guidelines and recommendations looking at what are the targets in patients with diabetes. This has been published a while back, and I'm sure you are quite acquainted with it. So the time in range in patients with type 1 and type 2 diabetes depends on the age. So in patients who are, well, it depends on the clinical status because age now is just a number. But recommendations are in most patients, you keep a target of about 70%, but more critical is the lower part here. So hypoglycemia should be kept less than 5%, and severe hypoglycemia should be kept less than 1%. In elderly patients, on those patients of higher risk of hypoglycemia, and those patients of high risk of severe hypoglycemia, it is a 50-50 split. You need to keep 50% within target, which is 70 to 180. And then the severe hypoglycemia should be kept less than 1%. So these are the current guidelines. And the first step to do when you have a lot of hypoglycemia is to back off from the insulin doses, then reassess if you need to add anything else. But you don't need to add any extra agent or any other treatment till you see the impact of your treatment. Back off of the insulin, reassess, and then decide. Okay, I hope I'm good with time. So this is my last question. This is a 16-year-old boy who was brought to this GP by his mother, who's concerned he might have diabetes. His mother has diabetes for about 12 years. And while at home, because she's worried about him, she just measured his capillary glucose randomly, and it was 230 milligrams per deciliter. And that's why she brought the patient, the boy to you. Well, his mother had GDM while she was pregnant, and this baby was large for date, or macrosomic basically. Baby was 4.4 kilograms. This boy has no symptoms of polyuria or polydipsia. He has always been overweight to obese since early childhood, and he has a sedentary lifestyle and a sweet tooth, which, well, most of 16 years old do have sweet tooth. Now, BMI is 32, blood pressure was 128/72. Now, we did the random glucose, it was 13, and a HbA1c was 8.2%, and you're waiting for the anti-GAD level. So what are you going to do in the meantime? So what is the best step in managing his diabetes? Lifestyle changes, see in 3 months. Metformin. Metformin plus degludec. Metformin and rosiglitazone. Metformin and semaglutide. Please vote. Okay. So the results are, again, a split vote. About a third, 32% said add metformin, start metformin and semaglutide. 32% said start metformin and degludec. Quarter said start metformin alone, and 13% said go for lifestyle changes and see in 3 months' time. So again, this is part of the guidelines that need to be taken into account, and people need to be aware of this because we have seen more and more patients at this age, and the treatment here is to give metformin and basal insulin, and it is very, very simple algorithm that's being published by the diabetes by the ADA. In those children who have, or adolescents who present with diabetes, you just need to look at what is happening with them. So if the A1C was 8.5% or less, you can give metformin. If the A1C is above 8.5%, you can start metformin and basal insulin at the same time. If they have symptoms of DKA or acidosis or HHK, then they need to go on IV insulin and be treated as type 1 diabetes. Now, once the anti-GAD antibodies are available, if they're negative, then you need to treat accordingly. Keep metformin on or start it on. Titrate up your insulin therapy based on blood glucose monitoring or CGM. If the second step, if the glucose targets are not met, then you can add GLP-1 agonist receptors that are approved in patients with type 2 diabetes. And these are semaglutide and liraglutide that's currently approved. Other option is to treat with insulin therapy intensively as you treat most of the other patients. Simply, if this is positive, you just need to go ahead and treat this patient as type 1 diabetes. You don't need to continue metformin based on the guidelines. So based on that, this is how they approach based on the guidelines for patients with adolescent onset type 2 diabetes. And I think I'm good with time, so I'm going to stop here, and I'm happy to take questions.
Thanks, Dr. Muhammad, for this interesting question. We have like a couple of questions. The first question, any precaution when adding phenol for patient already in SGLT2 inhibitor?
The concern about phenylron is related to potassium. So let's put it this way. We don't know the combination effects. Are they going to be beneficial or not? It might end up that phenylron added to SGLT2 inhibitor is like ARB adding to AAC inhibitors, right? But currently, these are all kind of, if there is no studies, they're just all gone kind of expert's opinion, you can put it this way. We don't know if there's anything we need to pay attention to, but what we need to pay attention to extra based on the use is the potassium. So the serum potassium has to be monitored, and if the potassium is high, the phenylron or have a tendency to have recurrent hyperkalemia, you probably don't need. You should avoid phenylron.
What will be the A1C target for people, frail and elderly patient?
Okay, so based on the guidelines, this has to be individualized, and guidelines are shying away from giving you targets. So the guidelines will accept HbA1c to be loose, and the loose definition is 8 to 8.5, and the tighter definition in elderly is 7.5. So you can well individualize the target of the patient according to the life expectancy, according to their frailty, and take into account the medication. So people with low life expectancy and very frail, you can be generous with the HbA1c because probably there's no benefit of tighter glycemic control. The focus is only on the quality of life.
Oh. In question 6, we noticed that stop insulin is the preferred method after gastric sleeve. When you will start GLP-1 to prevent weight regain?
Okay, so if there has been no intervention to prevent weight regain per se, there have been interventions to look at stopping weight regain, and that will be if the patient start to regain weight later on, then GLP-1 could be added in these agents. But as I showed you, there is a rapid reduction there's a slower reduction in weight gain in these in patients after the operations. Usually plateaus by 9 to 12 months. At that point in time, if they started to regain weight, then you might introduce something else after discussion with the patient.
Oh. Since we are in GLP-1 agonist, there is a question for type 2 diabetes who's also diagnosed with papillary thyroid cancer. Any precaution or no?
This is a very contentious question. So, well, there has been some data first of all, we know that these agents cannot be used in medullary thyroid cancer. Now, the issue of papillary thyroid cancer, there have been concern raised by studies specifically coming from France that suggested that patients receiving these agents end up with a high rate of papillary thyroid cancer. And this is an observational study. However, the main catch here is that the higher risk for having papillary thyroid cancer is doing an ultrasound scan for no good reason in asymptomatic patients. And that's what wasn't shown up in these agents. So we don't have any evidence that there is an increased risk. However, if there is any risk, as you will know, and especially when it comes to cancer, my personal preference will be not to use it if there is any concern at that point in time. As I said, no evidence, but I will avoid it. I will use something else.
So for other indication, do you just adjust before starting Fineron or no?
Adjust what? Sorry.
Adjust spironolactone if you add Fineron.
I don't think they need to be. I don't think they need to. They could be used together.
Okay. Any target A1C before elective surgery, and what's the target of A1C?
Okay, this is the HbA1c target for A1C is usually under 8.5 is acceptable. The normal, the better. Above 8.5, surgery is usually better to be delayed. Again, this based on the some of the guidelines of in-hospital management.
Okay. When you consider GLP-1 in type 1 diabetes?
All right. So the use of GLP-1 in type 1 diabetes is being studied or being looked at in small studies in the setting of managing of obesity. Not in the setting of managing for glucose. So when it's being used as smaller doses for glucose management, like exenatide at some point in time and liraglutide, smaller doses, the impact on glucose is very small. So insulin sparing effect is very small. However, when it's being used in terms of higher doses for weight reduction, you will get a better impact on glycemia and a lower doses of insulin. Lower dose of insulin, but these are all small studies. Nobody has done larger studies, especially with our newer agents, the more potent semaglutide 2.4 or tirzepatide. And they haven't done a lot of studies. But for in the setting of managing a patient for obesity per se, there's no reason why you should not give it to type 1 diabetes. You need just to be aware with the weight loss that you need to reduce the insulin doses and be aware of the high risk of hyperglycemia if you don't adjust your insulin.
For cardiovascular disease, will you consider SGLT2 inhibitor or not?
Sorry, the line just got cut off. What's the question? Sorry.
Okay. The question in type 1, with established cardiovascular disease, do you consider SGLT2 inhibitor?
Okay, again, these are very contentious questions. We don't know because it was not tested. Okay. Now there is a lot of momentum going around to look at. Nobody is paying a lot of attention to cardiovascular disease, but there is more and more attention being paid to kidney disease in type 1 diabetes, and there is a more and more interest in using SGLT2 inhibitors in patients with kidney disease in order to prevent diabetic kidney disease or delayed. So these are the area where we expect to have more progress here. The issue with SGLT2 inhibitors with type 1 diabetes is that they do seem to work. They do seem to reduce insulin doses. They do seem to reduce weight. They do seem to reduce CV variability when you look at CGM data. However, the thirst and the polyuria do not go away. It's not like type 2, because there is always glucose dumping in the urine. It's not going to go away. So the thirst remain there. The polyuria remain there. Some studies suggested that all the positive effect that we see initially are gone within a year. But we still have to see a longer studies. So I don't think we will have, or really in the future will hear anything about SGLT2 inhibitors and cardiovascular disease. But we will probably going to hear in type 2 and chronic kidney disease.
And she developed hypoglycemia. Is this something can be encountered or no?
You gave her what? Octreotide?
No, liraglutide, which is the Trulicity.
In patient with type 1 or type 2? Type 2 diabetes?
Yeah.
No, well, I say in medicine, everything is possible. So usually they don't have hypoglycemia on dulaglutide unless it's combined with sulfonylureas and insulin. But it will be unusual to have just hypoglycemia or any severe forms of hypoglycemia with these agents. I probably would have investigated this further.
Okay. If the patient started in metformin, and which A1C target you will consider adding the second agent?
Okay, so that is okay. So the default A1C target is 7%. That's the default. So if you're treating your patient to target, so 7%, if it's higher than 7% in 2 consecutive readings, 3 months apart, then you need to act on that. However, if you are treating patients and you set a different targets for them, then treat to the target. So you might set it 7.5, for example, or an elderly for 8, for example. Then it has to be your target not met for 2 consecutive readings, 3 months apart, then add an extra agent. But as I showed you early on, there is a big shift towards early combination therapy, both from the ADA and both from the ACE on patient with a high HbA1c, especially those who are young.
We have a patient with type 2 diabetes, normotensive and albuminuria. What's the preferable over each other, ACE or SGLT2 inhibitor?
So this has not been checked head to head. Almost all the studies that used ACE inhibitors in patients with chronic kidney disease, patients were already or either an ACE or an ARB. So what they did is we're thinking about majority of them are on ACE or an ARB. So you will find a small subgroup who are not, and they use this subgroup to do sensitivity analysis to show that it works whether there is ACE or there is no ACE. So currently we don't know. However, nephrologists and some diabetologists who did the analysis, some of the analysis, ACE inhibitors and angiotensin receptor blockers do not provide protection against progression to end-stage renal disease. So they do have no impact on the eGFR slope that I just showed you. They reduce albuminuria, they do that, but they do not impact the eGFR slope. They have no other impact there. So most likely that in this scenario, SGLT2 inhibitors might be beneficial. The question that we don't know, will the SGLT2 inhibitors work in the absence of any ACE or ARBs? So the subgroup analysis telling us that they do work, but preferably to be on ACE or ARB first. So I think in the future, we're going to see SGLT2 inhibitors becoming the first step in the treatment. The most recent KDIGO guidelines put SGLT2 inhibitors, metformin, statins, and ACE and ARB inhibitors at one line. Start them all.
Okay. In question 5, when you add canagliflozin, and when you will consider decreasing insulin dose while you're adding SGLT2 inhibitor?
That's a good question. So the worry that usually needs to take into account what are the chances of this patient going into euglycemic DKA. And it usually happens on those patients with a very high HbA1c, can happen, who might be, or those patients with a longer duration of diabetes that might be insulin deficient, slightly insulin deficient. So when these agents came into, became available, we were reducing the insulin and we're adding the SGLT2 inhibitors, and that seems to be a little bit cause harm, and there was more patient with euglycemic DKA. So I think the main important part is you might add the SGLT2 inhibitors. It depends on where your level of your patients are in HbA1c. If they definitely have a high HbA1c, I will not reduce the dose. If the HbA1c is lower, 8 or below, I might reduce the dose, worrying about hypoglycemia. But if the HbA1c is higher, I probably will not. I will use them in order to avoid adding extra insulin doses. And then monitoring is critical. So monitoring and making the decision later on is critical. But as I said, the worry about euglycemic DKA with this rapid reduction in insulin doses, introduction in an agent that shoots up the ketones level, that is a worry.
In question 7, like a non-alcoholic steatohepatitis, which would be your agent, GLP-1 or pioglitazone as treatment?
GLP-1.
Okay. Yes.
Yes. Yeah. No. Go ahead. So GLP-1. There are two studies, and they're all of them used they used liver biopsies, so they are beneficial, and they have the added benefit of weight reduction as well.
Okay. Here a question: can we start metformin if estimated GFR less than 45?
Yes, you can. So up to a GFR 30 or less, you can't. Between 30 to 45, it should be maximum of 1 gram a day. I showed you a clinical study that showed that you can use it up to 15 with a small dose of 500 milligrams per day, but that will be outside the license. Within the license and the guidelines, 30 mils per day, you have to stop. Metformin, 30 to 45, 1 gram maximum.
Okay. What's the role of Fineron in retinopathy?
Okay, I'm not aware of any roles of Fineron in retinopathy. nothing, something not aware of.
Okay. The last question: in elderly with long-standing diabetes with established cardiovascular disease and proliferative retinopathy, what caution to take to prevent worsening of retinopathy when starting tirzepatide?
All right. So again, this is a different question. So the main issue related to a GLP-1 agonist in retinopathy is that they do cause a rapid reduction in hyperglycemia, and that can cause a rapid increase, progression of retinopathy. That was seen with semaglutide, that was seen with dulaglutide, and that was seen with liraglutide in the past because of this rapid reduction in HbA1c. Do they have direct effect on the eyes? There is a specific study that looking at the eyes. What will I do? I probably will titrate up any agent I'm using slower than normal, and I will go slower in reducing the HbA1c in those in these patients, and I will keep a close eye on the retina during this process. I will not go for rapid titration. I will not go for a rapid decline in HbA1c.
Okay, welcome back after this long break for coffee and prayer. We'll have our second session of the day, which will be thyroid session. Our speaker is Professor Anwar Jammah. He's a professor of medicine in King Saud University and also consultant endocrinology and thyroid oncology and chairman of endocrinology diabetes division King Saud University. Welcome, Professor Anwar. Keep in mind, you can put your question and answer in Q&A. We have 1 hour and 15 minutes for the session, and after that, 15 minutes for the question. Welcome, Dr. Anwar.
Thank you, Dr. Naji. I appreciate your invitation. It's my great pleasure. Bismillah ar-Rahman ar-Rahim. So I'm Anwar Jammah. I'm a consultant in endocrinology from King Saud University. I have no conflict of interest. It's my subspecialty is the thyroid, so you feel free to ask any question in regard to my presentation, or if you have time later on, if you have any question, you're welcome to send it to my email, and we'll discuss it together, inshallah. So the MCQs in general, there is usually a short MCQs or long MCQs, and the short MCQs you can easily read it from the beginning, but the long MCQs is better to approach it from the stem of the last stem of the question. Then you can read the option. Then at the end you can read the case quickly if it's a long one. So that will help you not to lose time for no good reason. And in purpose, actually, I put some few questions that you may be able to answer it without reading the case itself. Okay, so we'll start by the first question. So thyroid hormone, and I put it in practice the T3 and T4. So if they mention a thyroid hormone, that mean the T3 and the T4. And the question here belong to which class of hormone? Steroid, protein, polypeptide, amino acid derivative. So which one is your answer? We can open the okay, so amino acid derivative, polypeptide, protein, steroid, and the answer is actually it's amino acid derivative. All right, so this is another question here. So thyroid stimulating hormone, which is the TSH, belong to which class of hormone? Steroid, protein, polypeptide, or amino acid derivative? Can we have the answer, please, or the voting? So usually this short question is okay. So can we have the voting? All right. So that's polypeptide, and the answer is a polypeptide. That's right. All right. So in this slide, I gave you the answer. This is, I think it's from Greenspan or something like this. The hormone showing here is the if you can see my slide here. So the rule of thumb here that most of the hypothalamic hormones and anterior pituitary hormone are belong to polypeptide or peptide protein, and so this is a rule of thumb. The other hormone, which is the sorry, the other hormone, uh, I don't know why is this one. So this slide showing you different hormone and different. So the steroid hormone that's include the vitamin D, the amino acid derivative hormones that include the T3 and T4, epinephrine, norepinephrine. So this slide will help you to differentiate or to know what's the type of hormone you are dealing with. So next question about hormone receptor. So thyroid hormone receptor belong to G linked receptor, cytokines receptor, G protein coupled receptor, TGF receptor, or nuclear receptor. Can we have the question, please, or the voting? So G protein coupled receptor. And this is right. So sorry, this is the we're talking about TSH or receptor. Thyroid hormone, as I mentioned, is T3 and T4. So T3 and T4 is actually the nuclear receptor. The thyroid hormone receptor is the one that you mean. The TSH is actually the G protein receptor. So and so if you can vote here, yeah, most of you know this. So the first question, we're talking about thyroid hormone, which is the T3 and T4. This question is talking about TSH and the yes, good. So I'm sure that you because we're talking about the TSH, maybe you jump to G protein receptor. So there is two types of receptor: the cell surface receptor and intracellular receptor. And again, the LH, HCG, and TSH, these three hormones that also have clinical association in the pregnancy and the first trimester thyrotoxicosis, all the seven transmembrane domain. The T3 and T4 are actually related to a nuclear receptor, and this also include the vitamin D. All right, so we're going to move to next question. So this is again is a short question, so you can start from the beginning. So this is a 35 years old male. He came from South Africa, known to have goiter, came to Saudi Arabia, presented to you after 3 months with history of palpitation, tremor. His TSH is undetectable. Which one of the following can explain his presentation? So we can have the answer, please. Excellent. So this is Jude Besedo effect. So this patient is from area that we think from the last update, it's deficient in iodine, and he came to Saudi Arabia. He can, or maybe he came to any other country, which is considered as iodine depleted, and because he has long-standing iodine deficiency, he may have goiter. Once you load him with iodine, he will have the Jude-Besedo effect, which is the result to hyperthyroidism or thyrotoxicosis. Okay, so this is an example of a long question that you may be, or maybe it's better to read it from the end. So which one of the following is most likely explanation to develop hypothyroidism in this patient? So is it failure to escape from Wolff-Chekhov effect, acute progression of Hashimoto thyroiditis, metastasis to thyroid gland, pathognomonic variant of the... Can you wait for a second, please? Or pathognomonic variant of gene encoding sodium iodine transporter. Now you can go back to the question. So this is a 23 years old. He had a new onset of hypothyroidism. And so he is known to have hypothyroidism. His current TSH is 85, and his antibodies is 1,000, and he presented with symptoms of hypothyroidism. And the main thing here in the history that he went for several contrast CT scan because of the renal stone. So he had multiple contrast CT scan, and he is now had hypothyroidism. Okay, so previously he has no hypothyroidism, but he had positive antibodies. Now he presented with hypothyroidism, and there is significant history of the contrast CT scan multiple times. And which one can explain his development of hypothyroidism? Can we have the answer, please? Perfect, very good. So again, iodine load in a patient with Hashimoto thyroiditis. All right, so this is a 41 years old. He's a businessman. He presented with TSH, low TSH, and high free T4. Has no symptoms of thyroid toxicosis, no family history of thyroid disease. Which one of the following may cause hyperthyroidism picture as a supplement? So you have black cohosh, you have biotin, fish oil, and calcium. I'm sure most of you know this question. So the answer is quickly is excellent. Biotin is very common substance that can cause picture of thyroid toxicosis, and it's very common in the MCQs for the last maybe 5 years. Next question. So yeah, this talking about biotin is taken as a supplement, and the picture that showed as thyroid toxicosis have effect also on parathyroid hormone. All right, and what you should do, you stop biotin even by 2 to 3 days before the testing, and that effect will be diminished. All right, so next question, 22 years man, fatigue, post-ablative hypothyroidism. So he had ablation with radioactive iodine for Graves' disease at age of 17. His brother recently diagnosed with hyperthyroidism, so he had a family history of thyroid hyperthyroidism. Now his TSH is 18, free T4 is 16. However, he's lucky to have his T4 done by dialysis. It was low, 0.6, which can go with the TSH of 18, and TBG of 21 is normal. Which one? The following cause his abnormal thyroid function finding, which is it thyroid toxicosis? Is it TBG excess? Is familial dyslipidemic hyperthyroidism or non-thyroidism? So the answer is excellent. That's most accurate option. It's autosomal dominance, so his brother had the same thing. And we'll move to next question. So this is a 32 years old pregnant lady presented with thyrotoxicosis. So she had thyrotoxicosis and her TSH is undetectable and free T4 is very high. Which one of the following deiodinase may help protect her fetus? It's type 1, type 2, type 3, type 4 deiodinase, and the answer is perfect. Good. So it is type 3, which presents the placenta, and its effect it's upregulated by the thyrotoxicosis. So it's one of the things that protect the fetus. All right. Which one of the following condition or medication results in a decrease or inhibit type 1 dehydrogenase? Is it beta agonist, adrenal insufficiency, hyperthyroidism, PTU, or carbimazole? And the answer is question, inshallah. It's PTU. So most of you decide it's PTU, and this is right. And this is a table also from Greenspan that's talking about type 1, type 2, type 3, and the factor that inhibit type 1 dehydrogenase. And you can see here the PTU, amiodarone, beta antagonist, glucocorticoid, and chronic illness. And also the type 3 dehydrogenase is present in placenta, and it's increased or upregulated in hyperthyroidism. Okay, we move on to the next question. Which one of the following may cause increase in the TSH secretion? So it's result in high TSH. Cabergoline, that's all affecting the TSH. Is it cabergoline, amphetamine, glucocorticoid, metformin, or heroin? That's maybe some of this substances commonly used. So the answer is amphetamine. That's right. So most of you got it right. Excellent. So the TSH secretion decrease by dopamine, by cabergoline, bromocriptine, glucocorticoid, metformin, opioid, and interleukin 6, and increase by the opposite, like dopamine blocker, and amphetamine, and interleukin 2. Which one of the following doing the T3 is important? You can read the option and you can give us the answer. So TSH22, free T4 of 7, TSH4, free T4 of 8, TSH suppressed, free T4 of 40, TSH 100. So the answer is, most of you got it right. So this patient had actually elderly patient with the TSH, low TSH and normal free T4. So you want to rule out the T3 thyroid toxicosis. All right, so this is a question which is a long one. So I prefer to, and this is the image provided with the question. And what is the most likely finding in pathological examination of this patient with mediastinal mass? Okay. Maybe we can wait for a second here. Is it ectopic thyroid tissue, metastatic thyroid cancer, normal mediastinal lymph node, or thymic? I think most of you had it right, huh? Yes, thymic. So simply, this is a 15 years old, present pediatric endocrinology. He had the treatment for thyroid cancer with radioactive iodine. And in the finding, he found this finding in the image. And the question here that the thymic tissue is a common finding in pediatric age, and there is a good uptake of the iodine, and it can be confirmed by SPECT CT or a simple CT scan later. Okay, I think we move on. So this is a 67 years old woman found the thyroid nodule, and that's found by CT scan incidentally. Maximum diameter is 9 millimeter. It's considered suspicious. Finding the aspiration is initially not advised. The nodule as a part of cancer to the thyroid, the reduced cytology suggests papillary cancer. The patient complete evaluation, it remains thyroid cancer, has no metastasis. The patient expressed interest to have her thyroid cancer followed with current treatment using active surveillance. So she opted to go with active surveillance. If present, which one of the following feature would support the patient decision for active surveillance? Is it extrathyroidal extension, evidence of coexistent hyperparathyroidism, new onset hoarseness, or patient age? So she had a thyroid nodule, small, and okay, that's right. So most of you got it right. So patient age is the reason why that you prefer not to go for surgery. I listed the criteria for immediate surgery. When you recommend immediate surgery, so if you found the lymph node metastasis, there is significant extrathyroidal extension, if there is invasion to the recurrent laryngeal nerve that can be presented clinically by hoarseness or by imaging or by examination by the ENT, or if there is another reason for surgery, which is the hyperparathyroidism, so the patient going for surgery anyway, at that time you can consider going for surgery. So this is the question. Assume close monitoring, titrate, adjust her dose. Which of the following is the best approach? So what dose of thyroxine you will choose to this patient? Choose. So you can read the question. I can summarize it for you if you want. I think we still have time. We are good in time. So she's a pregnant lady. She's known to have thyroid or hypothyroidism. She had problem with compliance. She had no cardiac issue. And now she presented with very high TSH, 119. The free T4 is very low. And the patient admitted that she stopped taking thyroxine. And the TSH now is 257. Free T4 is low, very low. And she wants from you to give her advice for her dose. So her previous dose before was 112. So you give 50% of her prior dose. You will give her 150, give her 125 daily, or you add free T3. The answer is she's pregnant now. Excellent. All good endocrinologists. So yes, you give her very high dose or the highest dose in the option. And this is because two things, that the patient is pregnant, so for fetal health, and for the patient herself. Okay. So this is another long question. So you can, in addition to low TSH, which one of the following result or combination test may be helpful to point to the diagnosis of non-thyroidal illness syndrome rather than central hypothyroidism? So, in my opinion, you don't need to go back and read anything. So here is trying to tell you how to differentiate between two. So you will help yourself with time if you answer this question quickly without reading the, and I'm sure you can do it. So can you give me the answer now? Okay. I think most of the people will get it right here. Okay, very good. Excellent. So yeah, so the low free T4, free T3, and high reserve T3. So in this case, as I mentioned, you don't need to read the stem. Of course, you don't need to read this also. Okay, so let's see this. Which one of the following is the most significant underlying risk factor for thyroid cancer in this patient? So he gave you the familial adenomatous polyposis, Hashimoto thyroiditis, B10 hematoma, serum TSH, Werner syndrome. Most of them have high risk, considered as a high risk. Can you please wait? Uh, can you please wait? Uh, so it's not going right here. Anyway, so this patient is 38 years old, Hashimoto thyroiditis. TSH is high, so the TSH concentration high is considered as a risk factor. She had ultrasound and 1.7. She recently diagnosed with breast cancer. Underlying treatment, her history is notable for oral papillomatosis in her tongue, acral keratosis, lipomas. Family history notable for her sister with headache and vertigo, a father with colon cancer, and mother with uterine cancer. So the answer here is, can we have the answer? I think most of you know it now with the extra question, with extra information. So B10 hamartoma, that's excellent. And I'll tell you now why. So there is major criteria for hamartoma. We mentioned the mucocutaneous lesion, the breast cancer, endometrial cancer. And this is present either in the patient himself or herself or her sister that she had endometrial cancer. It's follicular thyroid cancer, gastrointestinal. Her father had colon cancer, and so that's fit most of the major criteria of the Cowden syndrome or beaten hamartoma. All right, so we'll read this question. So 65 years old, comparing palpitation of serum TSH of undetected low serum TSH, free T4 1.5 or 19. And this is the normal, so it's high also. Free T3 is high also. Significant osteopenia. On physical examination, pulse is 84, her thyroid enlarged, several thyroid nodule, palmar moist, radioactive iodine is 21%. In discussing your rationale of treatment of her thyroid condition, which one of the following is supported by the RCT, which is randomized control trial? So this patient had low TSH and normal free T4 and normal free T3. Okay, so it's all within normal. So this patient has subclinical hyperthyroidism. Which one is supported by the randomized control trial? Treatment will prevent atrial fibrillation, cardiovascular mortality, it will prevent loss of bone density, it will prevent fracture, none of the above. Give me the answer. So, wow. Okay, so if 30% said none of the above, most of you said none of the above, so it's none of the above. And this is true. So there is no randomized control trials tell us there is a benefit of atrial fibrillation, cardiovascular mortality, or even fracture. Which one of the following recommendations is supported with grade A evidence? So treating subclinical now we shift to subclinical hypothyroidism. So you treat it with infertility, you treat pregnant with TSH of 2.5 and positive TBO, treat subclinical hypothyroidism with TSH of more than 10, treat patients with TSH of 9 and had history of heart failure, and none of the above. So this is a question for subclinical hypothyroidism. Give me the answer. So treat patient with subclinical hypothyroidism. So unfortunately, there is no grade A evidence to helping us to treat subclinical hypothyroidism. Okay. So these two questions, the subclinical hypothyroidism, subclinical hypothyroidism, We have to know there is no great evidence. We don't have very solid evidence to guide us in the treatment. However, there is a recommendation by the guidelines, but it's never reached to grade A. It's never reached to randomized controlled trials. We do this, but it's better for us to read in depth and know from where we got our science. Okay, so this patient, 22 years old, on physical examination, so he had a palpitation, nervousness, heart rate, he had proptosis, diffuse goiter. So he's in methimazole 30 daily atenolol. He had or developed hepatic transaminase 5 times more than the upper range. So he stopped the methimazole. Radiotherapy recommended, but the patient declined this treatment because of the proptosis. ATO, atenolol changed to propranolol. 1 week later, his thyroid hormone doubled and the liver function is rising. Which of the following is the best approach now? So he's having problem with methimazole. His liver function continue to be high. So give me the answer here. This is Kai. Give the maximum adrenergic, resume methimazole, start hydrocortisone, and surgery. You can see the answer here. Or give PTU. And the answer is, in this case that we see it commonly. So maybe every week we have similar case in the inpatient, and most of you get it right. It is surgery, but you have to give hydrocortisone, potassium iodide, and optimize the beta adrenergic blockade. All right, so this patient has a 2.2 centimeter TSH producing microadenoma, and his function is free T4. Free T4 is high, and his TSH is high, and he had MRI of sella torsica post-operatively, and it's decreased in size. But the patient continued to have secondary hyperthyroidism, as you can see. Which one of the following is the most appropriate initial intervention now? So he's not controlled by surgery. You give bromocriptine. Maybe you can give methimazole, somatostatin, thyroidectomy, or thyroid, which is the triiodine. So secondary hyperthyroidism, persistent post-op, the treatment is excellent. Somatostatin analog. Yes, so it's rare cases. We don't see a lot, but the treatment is it's really somatostatin analog. We have the monthly. That's explain the question. All right, so this is a 26 years old. She is separated with one child. Initial visit, her serum concentration 0.003. Other laboratory findings show the T3, the T4 high, and the TSH is also, the free T3 is high. Thyroglobulin level is 0.2, which is below the normal range. She reports mild fatigue and depression, although she is hyperthyroid. In physical examination, the pulse rate is very high. Thyroid gland is normal and palpable, and there is no proptosis. We did the nuclear scan, there is low uptake, and the answer is excellent. So most of you got it right. Thyrotoxicosis induced by the patient. So if you have thyrotoxicosis and no thyroid enlargement, and there is low uptake in the scan, so your option is few. So is it thyroiditis? This diagnosis will have high TG. If it's trauma ovary, you have to have a body scan, and you will see the uptake in the area of the ovary, or thyrotoxicosis, factitia, which is considered when there is a low TG, and the question is nicely give it to you. All right, so this is a patient, 66 years old, amiodarone. So there is no thyroid. I think there will be no exam without amiodarone question. It's common in the clinical practice, and there is lots of science behind amiodarone and thyroid. Very interesting to read. I advise you to read all about amiodarone and thyroid. So this patient had a TSH of 0.01, high frequency 4, and mildly elevated, total T3. Radioactive iodine is low. The thyroid ultrasound showed some nodularity and low vascularity. Methimazole started, and the cardiologist said, no, I'm not going to stop the amiodarone. But with the methimazole, the patient still have no improvement after 2 or 3 weeks of treatment. And which one of the following is the best next step management? We want to add lithium, prednisolone, thyroidectomy, replace methimazole with perchlorate, or replace with prednisolone. So you stop the methimazole and give prednisolone. The answer is excellent, very good. So the new trend actually in the treatment of amiodarone, more evidence that maybe starting the two medication together, the antithyroid medication and steroid, maybe initially or even after you try the methimazole for some time, is maybe of good benefit in controlling patients with amiodarone. Because as you may experience, that things get worse so quickly, and the patient is suffering. So yeah, so I advise you to read in detail the amiodarone-induced thyroid disease. Which one of the following vital signs considered to be high scoring criteria for the diagnosis of thyroid storm based in Warts-Fisky score? So there is a scoring for thyroid storm. I'm sure you all read about it. So is it A, B, C, or D? Give me the answer. So the first one include blood pressure, the second one heart rate and temperature. C is temperature and heart rate. D is heart rate and oxygen saturation. And the answer is, I think most of you should know this. Excellent, very good. Temperature. So temperature is always apart from the thyroid storm score, سواء Japanese score or Wartofsky score. Okay. So yeah, it's the only one have temperature, so it's the right answer. Oh yeah, I just I think you have it all for the scoring. All right, so this is a 77 years old woman, Hashimoto thyroiditis. Since age of 42, so more than 30 years, maybe more than 30 years. She had rapid thyroid enlargement over the course several weeks. maybe you don't need to read the rest of the stem. But anyway, her serum TSH is okay, TBO is high, ultrasound show markedly heterogeneous gland with 5.4 centimeter left side. Finally, the aspiration performed and show this image, which showing lots of lymphocytes. The question is, which of the following the best step in the management of this patient? Give her a scan. Repeat the fine needle aspiration with flow cytometry. Repeat it with gene classifier testing or thyroidectomy. And the answer is long-standing Hashimoto with rapid increase in hair. All right, so most of you got it right. Yeah, so long-standing Hashimoto, rapid increase in the size of the thyroid and lots of lymphocyte in the sample that suggest going with lymphoma, and you need flow cytometry. Sometimes the pathologist will prefer to have bigger biopsy, either surgical biopsy or a true cut biopsy to diagnose it. So this 77 years old woman had a history of papillary thyroid cancer 5 years ago. And she received 100 MCI, and there was uptake in the thyroid. 3 years, she underwent a repeated treatment with 100 MCI, so she had total of 200. Post-treatment, her serum thyroglobulin not changed, and she's on levothyroxine. On physical examination, her blood pressure is 128%, so pulse, so 84, so okay. No palpable thyroid tissue. Her TSH is okay, 0.2. I don't know if this is okay or not, we'll see. Thyroglobulin antibodies, and thyroglobulin is 11, so had positive thyroglobulin, more than 10, non-suppressed, okay? With normal TSH, with suppressed TSH. Her thyroglobulin has been stable for the last 3 years. In neck ultrasound, there's no sign of tumor, no foci, so she went for PET scan and negative. She had DEXA for her routine checkup for the osteoporosis. She had T-score of minus 2.7 the spine and the hip, but no fracture. Which the following is the most appropriate strategy. Continue the same levothyroxine, increase levothyroxine to suppress the TSH to the target, which is we advise for thyroid, most of the thyroid cancer patients 0.1. Do a diagnostic iodine 123, treat with radioactive iodine, and another one, or treat with sorafenib. The answer is, so she has biochemical incomplete with highish TSH, and the answer is leave her alone. Yeah, that's the right answer. So TSH 0.2 is just okay for her. Elderly lady with osteoporosis, it's better to avoid hyperthyroidism problem with her. She will be doing fine for the rest of her life without any intervention, even with changing her levothyroxine dose. She will be fine. So this is a 20 years old. He had attention deficit disorder, referred because of palpitation, normal thyroid function test, with no compressive symptoms. On physical examination, his heart rate is highish and diffuse goiter without nodular fluid. Tremor is absent and has normal deep tendon. The TSH is 4.3. The free T4 is 34. Radioactive iodine is 35%. Alpha subunit of pituitary glycoprotein hormone 0.3, which is normal. 6 hormone binding hormone 3, which is normal. MRI show normal appearing pituitary gland. Results from heterophils antibodies are negative. All right, so you can repeat it quickly. And we'll move now. So which one of the following is the most appropriate next step in this patient management? No intervention, refer for thyroidectomy, start methimazole, start propranolol, or treat with radioiodine. Okay? And the answer is very good, excellent. So most of you got it right. So just start propranolol. This question is classical for thyroid hormone resistant and thyroid hormone resistant is very rare. Uh, it's maybe not rare, but in our practice we don't see it uh, commonly. And you can see here that the signs and symptoms of associated with the disease. Um, so this patient just need proper knowledge. Okay, so this is 60 years old, male, heavy smoker. That's very heavy smoker, 80 back here. Was referred to you by his doctor with TSH level of 0.001, 3 to 4, 44, gradual reduction in visual acuity, diagnosed with Graves, hyperthyroidism. Later on, 9 years earlier, and ever since, in the regular treatment with carbimazole, the patient had I-130 treatment in July 2018, and on his initial, he had low visual acuity and corneal breakdown. Which one of the following is the preferred therapeutic option for sight-threatening TED, thyroid eye disease, that is um, very very attractive area now, trending the TED or thyroid eye disease, and I will not be surprised to have one or two questions about thyroid eye disease. And the answer is which one you're going to give this patient? Wow. Okay, so this is, I think I choose easy question, easy target question, which is the sight threatening. So if we have a sight threatening TED, the only option is IV glucocorticoid. If you have IV glucocorticoid among your option, this is the right answer, okay? If it's sight threatening, all right? Then you consider orbital radiotherapy. The other option, which is coming in the new data, that's actually mild to moderate TED. But for sight-threatening TED, the answer is always IV glucocorticoid. I give you some slide here talking about diagnosis, how to screen, what alerts the patient, how to prevent the progression, and when to refer to specialized area, how to classify it, and how you talk about activity, and what is the treatment option for the eye disease. And you can see here, it's the one that I focus on, the sight-threatening TED, and the preferred therapy is always IV glucocorticoid, and you can consider radiotherapy. I hope you can, you are free to use my slide. It's all yours. If you don't have it, you can email me and I'll email it to you. All the questions. So this is 25 years old with history of suboptimal controlled thyrotoxicosis, became pregnant. She's currently treated with methimazole. The patient continue her current treatment regimen. Her fetus will be, so if she, or you don't have PTO, so the patient is methimazole and you need to continue. Which one of the following has increased risk to develop for her baby? Biliary atresia, cleft palate, esophageal atresia, placenta previa, spina bifida. Give me the answer. Okay, very good. Okay, that's that's very good. So methimazole, the first trimester associated with aplasia cutis. This is the most maybe common things that we're talking about. So I gave you something atresia, so you can remember. And I just put it here, so maybe anyone can come in the question. So this is at 26 years presented for evaluation. She is a pregnant 15 weeks. Her first child. Laboratory test show TSH 0.11, T4 14.8 normal, total T4 15.5 highish, total T3 280 high, thyroid stimulating immunoglobulin 140%. She reported mild fatigue but otherwise feel okay. Morning sickness early in her pregnancy, but this has resolved in the last 3 weeks. On physical examination, heart rate is okay, and palpation, gland is non-tender, 20 gram, without nodule, no proptosis. Which of the following is the best option? Plan thyroidectomy in the second trimester, repeat thyroid function in 4 to 6 weeks. Start atenolol, start methimazole, start propiothyroxine. And the answer is, yeah, very good job. You're doing a great job. It's very clear question. All right, so this is 75 old women admitted to medical care unit, intensive ICU, with progressive obtundation, and found to be she's in myxedema coma. She treated with IV levothyroxine, stress dose, so they're doing well here. After 84 hours, the patient gradually improved, but developed progressive hypotension with narrowing of her pulse pressure, pulsus paradoxus, and diminution heart sound. ECG show low voltage. Laboratory test TSH is 2.8 and free T4 is almost normal. Serum cortisol is okay because she's on replacement. Serum creatinine kinase is mildly elevated. Which one of the following is the most likely cause for patient change in clinical status? Is it adrenal insufficiency? Her cortisol, you can remember, is low, but she started on replacement. Cardiac ischemia, cardiac tamponade, cardiomyopathy, or inadequate thyroid replacement, given the result you have. Okay, so what is the answer? Excellent. Why you did this? Because pulsus paradoxus, low voltage ECG, myxedema coma, very common finding, very common complication, cardiac tamponade. And this is the cardiac tamponade, this is the X-ray. All right, so this is a 63 years old, stage 4 medullary thyroid cancer, referred for consideration of further therapy. Diagnosed 8 years ago, believed sporadic, post-operative elevation of serum calcitonin. So from the beginning, her calcitonin is high, and she had distant metastasis to the lung bilaterally and drip 1 year ago with disease progression. So she had a progression of the disease. Testing for germline is negative. Physical examination is otherwise normal. Calcitonin is 14,000, and CEA is 72. Your answer is most appropriate. Next step, chemotherapy, octreotide therapy, radioactive iodine treatment, radiotherapy of the lung and the rib, or fendatinib. The answer is, give me the answer, please. And so what is the answer? Excellent, good job. Perfect. That's very easy group. Okay. So yeah, so this is, so she had a metastasis and there is progression in the metastasis. That's enough to consider fendatinib or cabozantinib. So 37. So young, 37. Thyroid nodule, ultrasound, 4.6. Hypoechoic nodule, calcified, hypervascular. No suspicious lymph node. So there is no lymph node. FNA showed finding of follicular neoplasm. So FN, also class 4. And repeated FNA with molecular testing showed RET BTC rearrangement. RET BTC rearrangement. Which one of the following is the best management for this patient? Lobectomy, total thyroidectomy, total thyroidectomy with bilateral neck dissection. Repeat FNA in 6 months, repeat ultrasound 6 months, and give me your answer. Excellent, very good. So most of you got it right. So it's 4.6 centimeters. So by all means, this patient will require total thyroidectomy and radioactive iodine. So better to go with total thyroidectomy in the beginning if the size is more than 4 centimeters. Plus, this patient had follicular neoplasm, risk of cancer is more than 35% or almost 35%. Plus, she had molecular analysis of a common mutation for thyroid cancer that indicate all that patient is a good candidate for total thyroidectomy and most likely for radioactive iodine ablation. All right, so this is 83 years old woman with refractory atrial fibrillation. Is prescribed amiodarone. 3 months later, he reports increasing palpitation and diaphoresis. On physical examination, 90 per minute, her thyroid gland is normal in size, non-tender, and he has a fine tremor, so he had a fine tremor. Which of the following will be the most specific indicator for thyroid toxicosis in this patient? So this question is, again, talking about amiodarone and the effect of amiodarone in the thyroid, in the level of the thyroid itself, in the level of the receptor, in the level of the uptake. So is it clinical sign and symptoms? Is the amiodarone have something to do with this? Elevated free T3? Is the amiodarone have anything to do with T3? Elevated total T4? Low iodine uptake is any effect of amiodarone or suppressed serum TSH? So which one of the option is a good indicator in thyroid toxicosis in this patient who's known to have or he's on amiodarone and you know he had thyroid toxicosis? So which one you tell, oh, this is from amiodarone? And the answer is excellent. Wow. Oh, super group, super group. So it's TSH, suppressed TSH. Amiodarone affect the clinical sign and symptoms. So patients with thyroid toxicosis on amiodarone, they don't have the full symptoms and full signs because of the block of the T4 to T3, also because of the effect on the T3 receptor. The amiodarone is look like T3, so it may affect the T3 receptor. Total T4, it may be affected. Free T4 is the best option. The low radioactive iodine uptake is almost always with all our patients, especially with the amiodarone, because they have iodine load already there. So I think the TSH is the best answer here. The low TSH is the best answer. All right, so 52 years old women with lateral neck mass found to have papillary thyroid cancer, metastasis to lymph node. So she had metastasis to the lymph node, confirmed by fine needle aspiration. And undergo total thyroidectomy with central and left lateral neck dissection with removal of 1 centimeter tall cell variant papillary thyroid cancer. Involve lymph nodes, both left central and lateral. Post everything, she received radioactive iodine, and she found to have a metastasis in the pulmonary area. So numerous pulmonary metastasis from the thyroid cancer. And which one of the following? Okay. All right. Which one of the following is corresponding to new AGCC8 staging? Stage 2, 3, 4, A, 4B. And the answer is? Okay, fine. So yeah, barely win. So yes. Stage 2. Why? Age. Okay. The new AJCC consider 55. So anything below 55, any person, male, female, below 55, there is no longer stage 3 or stage 4. Only 2 stages. One with metastasis, one without metastasis, 2 with metastasis. More than 55, you can consider stage 3 and stage 4 and talk about them. But this question is very straightforward. Okay, so this is the 8th edition of AGCC, and it's showing you the stages 1, 2, less than 55, more than 55. You have 1, 2, 3, and 4, and this is the 10 years disease-specific survival. All right, so this is a 49 years old woman just undergo total thyroidectomy, 3 centimeter nodule. This is the 6 on cytopathology. Surgical pathology, so the right side 3.2 unifocal classical variant papillary thyroid cancer. 4 out of 6 resected central compartment node were positive for tumor. The tumor foci is 0.1, 0.2, and 0.3 largest dimension. So there's 3 lymph nodes, 1 and 2 and 3 millimeter. Okay. No lymphovascular invasion, no extrathyroid extension. Preneural invasion was not identified. We followed the discussion. Next step of her treatment. Are you going to give radioactive iodine? If yes, how much? Or no radioactive iodine? Second surgery, they suggest another surgery. So another questions. So you give radioactive iodine, no radioactive iodine. If you give is 30 or 100, or you consider another surgery to clean the central neck and lateral neck. Perfect, very good. Excellent. So yeah, no radioactive iodine. This is considered a low risk patient. If you want to be very, very suspicious in those patients, you can actually monitor them with thyroglobulin in 6 weeks, maybe in 2 months, and to see if the thyroglobulin going either the thyroglobulin itself level, or if you have a baseline and you decrease the. So this is a slide coming from the last ATA guidelines. This may guide you to treat. So there is definitely no radioactive iodine. It's less than 2 centimeters for all minimally invasive follicular thyroid cancer. And here you have to discuss with the pathology, is this really minimally invasive follicular thyroid cancer? Sometimes you need to give a call if you think there is query about vascular invasion. So confirm it with your pathology before. You definitely give high dose radioactive iodine ablation in the lower part here. So you give 100 MCI or high dose. If you have follicular thyroid cancer with extensive vascular invasion, if you have a gross extrathyroid extension that the surgeon will tell you about, if you have extranodal extension in the lymph node, if you have extranodal extension, or if you have a lymph node more than 3 centimeters, yes, in this case, you give a high dose, or if you have metastasis. You consider low dose if it's only the size more than 4 centimeters, if you have extrathyroidal extension more than 2 centimeters, if you have a papillary thyroid cancer with vascular invasion. So vascular invasion is different. It's papillary thyroid cancer, follicular thyroid cancer. And the age we think from the most of the evidence that more than 45 years, it's better to treat with radioactive iodine more than 2 centimeters. If you have more than 5 lymph nodes, or if the lymph nodes involved in the lateral compartment, we suggest to reevaluate with thyroglobulin in 6 to 12 weeks or 2 months if you have in between. So they stay 2 to 4 centimeters. If you have minor extrathyroidal extension, if you have somewhat less than 5 lymph nodes, or if the size 0.3 to 3, like the patient in the question that we mentioned. That's maybe the best answer. If it's there, I may go with it to reevaluate the thyroglobulin level in 6 to 12 months. All right, so I think I reached to the end of my presentation. I hope I and finish on time.
Okay, thank you, Dr. Anwar. And we have maybe plenty of time for question. I have a couple of questions. The first one, is it better to reduce the threshold of FNA in a nodule of lower posterior location that near the vessel or trachea?
Yeah, definitely. I always look to my module. So in the purpose of exam, if you have uh, a picture of ultrasound and you see the nodule, either it's in the beside the trachea or beside the aortic aorta or beside the muscle, and you think there is invasion, even if it's less than 1 centimeter, we usually, and the question may be directed or directed you to answer, yes, I will do biopsy this patient, even if it's less than 1 centimeter, if the location is not is not intrathyroidal. So extrathyroidal extension or near to the triangle, the dangerous triangle, which is in between or in the the lateral triangle to the trachea, which is include the laryngeal nerve, the recurrent nerve.
Threshold of neutrophil count to stop carbimazole in case of suspected agranulocytosis.
So yeah, agranulocytosis definition is less than 500, and maybe less than 1,000. We as a neutrophils, we consider to stop.
Okay. What's the appropriate dose regime of potassium iodide and its duration before proceeding to thyroidectomy in case of Graves' disease?
So we usually start at 5 days before, and we give 5 drops. It's usually prepared. I think it contains maybe 5 milligram of potassium iodide. We give it TID for 5 days before the surgery.
How to treat subclinical hyperthyroid in elderly patient with undetectable TSH and cardiac patient, but his VT4 level is lower normal, like example 13.5.
Yeah, so the guidelines will tell us this is should be treated if the TSH is less than 0.1 to prevent the atrial fibrillation and for osteoporosis. My question was, is that the MCQs was, is that based on randomized control trial? The answer is no, it's not. There is randomized control trial, and there is no increase in atrial fibrillation, no increase in mortality, no increase in cardiovascular disease, and no increase in fracture. But because all of this is common in elderly patients, we and the guidelines, and we are in clinical practice, we treat them with usually we treat them with oral antithyroid medication and try to reach to at least TSH more than 0.1.
Here a question about precaution for antithyroid medication during breastfeeding. Is it safe? And any monitoring for that?
Sure. So the carbimazole is used in breastfeeding, but there is a dose that we usually don't exceed, which is maybe 15 milligram. Again, is that based on evidence? No, the answer is no. But we traditionally we use 15, maximum 20 milligram of carbimazole during the breastfeeding, and it showed no significant amount of carbimazole transferred to the baby.
Probably this not was a question, but there's a question. What's the indication for radiofrequency ablation and thyroid nodule?
Okay, so you have to have symptoms of compression. If the patient have problem with swallowing or problem with breathing, or there is if the patient doesn't like to see the enlargement, I mean cosmetic reason. So that's all indicative to do the radio frequency ablation. But before, as most of the guidelines mention, that you need to do at least 2 FNA is to confirm this is benign. Sometimes one is enough if the ultrasound feature is very suggestive of benign lesion, and I think it's coming more nowadays.
Okay. Is there an indication? Yeah. Is there any indication for treatment of hypothyroxemia in pregnancy?
Hypothyroxemia.
Yes. TSH normal and thyroxine slightly low.
Low? No.
Yeah.
Sometimes you have the T4 during pregnancy. There's T4 will be low, and but if the TSH, what first thing I go with, I target is the TSH. So the answer is no. If the TSH is normal, things will be okay, inshallah.
The lymphatic invasion is considered as intermediate or high risk in initial stratification.
Lymphatic invasion is always come with vascular invasion. So it's called lymphovascular invasion. It's sometimes for the pathologist is difficult to know this is a lymphatic or artery or vein or capillary. And as we mentioned quickly, that the invasion in follicular thyroid cancer is so follicular thyroid cancer with more than 4 lymphovascular invasion is considered very high risk that need very high or the highest dose of radioactive iodine. It maybe doesn't matter a lot with papillary thyroid cancer, but it's also increased the risk of recurrent, and that showed in most of the study. I think in our study, maybe in your data, Abu Ahmed, you have that lymphovascular invasion also is considered as a high risk for structural incomplete disease in the long-term follow-up.
Any rule for measuring calcitonin in patients with thyroid nodule?
I rarely use it. So if I suspect medullary thyroid cancer, let's say for example, if you have family history, if you have MEN suspicion, if you have patient who had pheochromocytoma, if you have sometimes I do it for a patient who had very high in the zone, in the upper zone of the thyroid. If we have nodule there, I may go with doing the calcitonin, but there is no place for a normal daily cases.
In a patient with depositive lymph node 0.3 centimeter, any indication for radioactive iodine?
3 millimeter. 3 millimeter يا ابو احمد ولا 3 سنتيمتر؟
Yeah, 3 millimeter.
3 millimeter. 3 millimeter.
No, 0.3 centimeter, which is 3 millimeter.
3 millimeter. Yes. So this is considered as an intermediate risk that it's in the edge. So more than 3 millimeters you can consider small dose. Less than 3 millimeter you consider no radioactive iodine. I will do the thyroglobulin post-operatively and reassess the patient. If it's only one risk factor for this patient, I may do the thyroglobulin and follow it maybe for 2 to 3 months to 6 months, and we can consider radioactive iodine anytime up to even 2 years. If the thyroglobulin is not going down, and if there is any evidence of recurrent of disease, we can consider radioactive iodine at that time.
To approach a patient with subclinical hypothyroid, for example, TSH 5 or 6, with recent diagnosis of cancer and plan to start pembrolizumab, with checkpoint inhibitor.
Yeah, so that affects the thyroid hormone, and maybe we start because we are expecting to have more hypothyroid, more higher TSH and maybe hypothyroid.
Okay. Here a question: a case of a patient in his 70s with radioactive iodine refractory disease with lung and bone mets. He will be started on TKI. what's your recommendation about his level of TSH suppression?
So he had metastasis and he had progression. So
Yes,
he
and he's 70 years, yes, refractory.
and he fulfilled the criteria for TKI.
Yeah.
Okay,
So here's the question about his TSH suppression.
Maybe if he's fit for TKI, he may be fit for TSH suppression. I know that the risk of treatment, but my rule of thumb, if this patient is can tolerate the TKI, he will be able to tolerate TSH suppression, unless if there is atrial fibrillation or documented osteoporosis, we can reduce. Yes.
Okay.
But
When
the
can we use
benefit of TSH suppression, I think it's outweighed the TKI in such patients.
Tepro for?
I can't hear you, Abu Ahmed.
Okay. When can we use? Yeah. When can we use Tepro for the eye disease, Graves' eye disease?
Yeah, there is if there is a moderate uh, moderate TED, and I think this is something that you need to discuss with the ophthalmologist. And I personally never use it, so I'm maybe not the best person to answer this.
Okay. What kind of radiation exposure can affect the thyroid?
So there is two effects of radiation exposure or iodine radiation. So there's two effects. One effect is the thyroiditis and hypothyroidism risk. This is one, and the thyroid cancer, which is mainly papillary thyroid cancer. In the two effects is, so for the first effect, which is the thyroiditis, is present all the time. When there is any exposure to radiation, the thyroiditis and hypothyroidism is there, elderly or in child. For the thyroid cancer effect, uh, from Chernobyl data, we always believe it is more to have thyroid cancer or radiation-induced thyroid cancer if you have the radiation exposure early in the life. So let's say in the infancy, in childhood, in up to 19 years old. So exactly from Chernobyl data, 19 years old, more than 20 years old, the risk of having thyroid cancer is similar to the population who exposed to radiation, similar to the patient not exposed to the radiation. So the radiation exposure after the age of 19 or 20 may result in thyroiditis or hypothyroidism and not thyroid cancer. So that's what we learn from Chernobyl data.
Okay. What's the strategy for surveillance in micro PTC and for how long? There is no surgery.
Yeah, there is the guidelines mentioned before. We said 20 years, then 10 years. Now they said 5 years. If there is no evidence of disease, you can stop following the patient in your clinic and refer it to the primary care clinic. And so micro BTC, I can't remember any case that we have a problem with micro BTC later on. So maybe 5 years is enough. If you ask me personally, I did not discharge any patient yet with micro BTC. I'm following them every 2 years maybe, and they all do well. Although the clinic is it's having more patients now. I don't know what you do.
When you label a patient with Actually, 5 to 10 years, if they are in remission, just we can discharge them, but for their primary physician. And if they have anything, they can refer back. In clinical practice, when to label a patient with radioactive iodine refractory disease?
So there is a list of condition uh, for to define the radio iodine refractory disease. So if the patient reached to the maximum dose, if there is no uptake, if there is uptake and there is a progression, if there is there is uptake and there is a progression, if there is partially uptake and some of the tumor did not uptake, that's considered also refractory. And there is I think this is a new definition, another if there is uptake to the part of the tumor and there is no uptake for the other parts of the tumor, that they consider it radioactive iodine refractory disease.
Okay. In terms of ATA risk classification, how to classify follicular thyroid? Is it similar like papillary thyroid cancer?
Almost. Yes.
Oh.
The follicular thyroid cancer, in all of the data that we have, it is included with the papillary thyroid cancer. The only difference that I always remember is the vascular invasion. The vascular invasion follicular thyroid cancer carry more risk, and we aggressively treat this with the follicular thyroid cancer. Again with the papillary thyroid cancer, but the vascular invasion of papillary thyroid cancer is maybe less risk of follicular thyroid cancer.
Okay. If TSH normal on high dose biotin, would you repeat off biotin as patient may be hypothyroid?
Wow, that's smart. Yeah, I will. We will stop biotin. We will stop biotin anyway before the thyroid.
Okay. In pregnant lady, and do you check both antibody, anti-TPO, and anti-TG? And what if one positive in subclinical hypothyroid? What is if about one positive and the other negative?
Yeah, the data actually is built on a TBO. It's TBO data, but I think even it's the if you have also the positive anti-TG, that may count, but most of the data, most of this evidence we have is based on the anti-TBO.
Okay. There is a question about amiodarone, like steroid use. If you decide to start the patient with steroid, what's the dose and duration?
Dose of the steroid? Yeah,
and duration.
the steroid is, I think there is maybe suggestion of 30 milligram or so, 0.5 per kg, and I think the maximum time that I go for is maybe 6 weeks and reevaluate.
Okay, the last question: any indication for radioactive iodine for tall cell micro PTC?
Yeah, tall cell is one of the risk or high risk cells in thyroid cancer, but is the radioactive iodine going to change the nature of the aggressiveness of tall cell? The answer is definitely no. So if you give radioactive iodine 100 or 200 or 300 or maybe 30 for tall cell variant, because it's in the cellular level, and the iodine penetration to it is less. So giving iodine, giving high dose of iodine may not change the nature of the tall cell, but it's still considered a high risk feature of thyroid cancer.
Okay, thanks, Professor Anwar, for this nice presentation and answering all of these detailed questions.
It's my pleasure.
Okay, and we can conclude.
Pleasure to be with you, Ahmed, and for the fellow that's I always like to discuss with them any topic.
Okay, thanks, and thanks for all the audience. We will have just you need to log out, then log in 5 minutes. Then we'll start our next session with Prof. Amir Hamrian for adrenal with Dr. Wiam Hussein. Thank you all.
We are very fortunate to have with us for the last session today a renowned speaker. He's known to all of you. Dr. Amir was with us in Abu Dhabi for at least 4 years, and he was very active. We all met him. We all listened to his talks and learned so much. Alhamdulillah, we're still learning from him until now. Inshallah, tonight you will learn a lot. I know Amir always provide very nice and practical data for everyone. And Amir, if you remember, he was with us in Cleveland Clinic, Abu Dhabi. He was the head of Department of Endocrinology and Diabetes. He came from Cleveland Clinic as he was an attending physician there, and he was the program director for fellowships in the Cleveland Clinic. Now he's back to Maryland for the last 4 or 5 years, and he's busy there. He's the medical director of the Adrenal Center, and he's actually an associate professor of medicine. We are very privileged to have him. And Dr. Amir, you can start with your presentation.
Bismillah ar-Rahman ar-Rahim. Thank you, Brother Hussein, for the nice introduction. Let me share my screen. So I want to thank the organizing committee for the nice introduction and for the invitation. And it's an honor to be part of this program. I have 32 questions, and I knew that we probably would not be able to finish them. But I thought maybe I should leave them, and you can look at them, whatever we can do, and the rest of them. And if you have any question about need any explanation, you can reach out to me, and I'll be happy to help out. The amount of time I will spend depends on the answer that I see, and I may stay less or longer on a particular question. And I will make sure that, of course, our chair also, that I have enough time at the end for Q&A session. Okay, so let's move on. These are my disclosures. So the question number 1, which of the following about the adrenal insufficiency workup is correct? A delta cortisol less than 9 is suggestive of the secondary adrenal insufficiency. Using monoclonal cortisol assays, a total serum cortisol level less than 18 microgram per deciliter at 30 minutes during the standard cosyntropin stimulation test is diagnostic of adrenal insufficiency. Immune check inhibitors can only result in secondary adrenal insufficiency. A serum-free cortisol level of 0.9 microgram per deciliter correlates with the total serum cortisol level of about 18 microgram per deciliter. And a DHEAS level above the lower limit of the normal range can be used to rule out adrenal insufficiency. Okay, we have a significant split here. Okay, so let me go over this question in a bit more detail. So we have the correct answer is D. A serum-free cortisol of 0.9 microgram per deciliter correlates with the total serum cortisol about 18, and this comes from the study was done at Boston in about more than 300 patients. So first of all, I think it is important for my talk that we clear about have a clarification about what the normal response is during the cosyntropin stimulation test. Now, using the standard immunoassays in the past, which are based on polyclonal antibodies, a cortisol level more than 18 or 20 have been used as a pass criteria. Now, there has been a number of the studies, and I have listed all of those for you, that the second generation, the immunoassays, including Alexis, for example, cortisol assay that we use, or mass spec. I'm sure you're using a monoclonal antibody-based immunoassay in your country too. A cortisol level cutoff about 12.7 to 17.5 has been used as cutoff criteria. However, this data has a lot of problem with them because many of these publications, they have combined the 1 microgram and 250 microgram cosyntropin stimulation tests. They include patients who had exposure to glucocorticoids and opioid. Lack of distinction between 30 and 60 minutes cortisol value, because as you know, when you do the standard dose cosyntropin stimulation test, always the 60 minutes, almost always more than 30 minutes value. And then combining the ambulatory and inpatient population with some inherent problem with the inpatient, including low CBG. One thing is important to remember is that when you do 1 microgram synthropin stimulation test, and there's nothing wrong to doing that, but when you do that, you need to remember that you can't use the same cutoff. The cutoff is going to be lower, and usually the time point probably would be about 20 to 30 minutes, 20 and 30 minutes after the 1 microgram. But we almost always use the standard dose. So the same cutoff cannot be used for these two tests. So bottom line, and we have done this study at our institution too, is that, and using carefully excluding patients with the glucocorticoid opioid exposure, is that a cortisol level more than 14.5 or 15 microgram per deciliter at 30 minutes, and a 17 to 18 can be used with these newer assays or mass spec to rule in or rule out adrenal insufficiency. This was the study I was referring to, was done at Mass General Hospital, more than 300 patients, including patients on estrogen, some ICU patient, about 20, 30 patients, some patient in inpatient and controls. And they did the ROC curve, and they found that the 0.9 microgram, and this was done by mass spec, a level of 0.9 microgram per deciliter correlated best with about 18 microgram per deciliter, with a very good sensitivity and specificity correlating together. Now, we had a question about the DHEA. So DHEAs can be used, and this is from Dr. Arafat's group, and this kind of algorithm they showed that in cases when the cortisol is indeterminate, and with the newer assays probably can change that number to 5 to 10 microgram per deciliter. Having a normal DHEAs can be confirmatory, and you don't need to do any further evaluation. However, just remember that when the people getting old, the normal range for DHEAs can be, for example, in an 80-year-old can be that 10, 15 microgram per deciliter. The DHEAs needs to be above 55. So it should be in the normal range, but when you look at the kind of older patients, it should be above 55 microgram per deciliter. So the DHEAs can be used in addition to the cortisol, in conjunction with that, for evaluation of adrenal function. I put this image I thought would be important, and the aim of this talk is for board review and also your clinical practice. Sometimes when you don't have, and you think the patient has a secondary adrenal insufficiency and you may not have an MRI study and it may be expensive and the cost for the patient, you can look at the CT studies. And here you can see a CT study, and you can see the pituitary gland, and here on the coronal and sagittal views, and you can see the stalk and pituitary gland. There is no cellular mass. So sometimes this can help you to evaluate if there is any cellular mass or not, just by looking at the CT scan. It could not be perfect. It will not be rule out, for example, a hypophysitis, but it can be help you with if there is a cellular mass or not. Let's go to question number 2. Which of the following statements about opioid-induced adrenal insufficiency is correct? Any patient taking more than 5 to 10 milligram morphine equivalent per day should be evaluated for AI. The recovery of the HPA axis is common after stopping narcotics. Only certain opioids can lead to secondary adrenal insufficiency. A minimum duration of at least 6 months of therapy with opioids is necessary to result in adrenal insufficiency. About 60% of patients taking more than 20 milligram morphine equivalent doses for more than 3 months develop secondary adrenal insufficiency. Please queue answers. Okay, about half of you answered the correct question, which is answer B. And let me just go briefly over that with you. Some of you said the answer E, but that is not correct. It's much less than 60%. So in a study that was done by Mayo Clinic, so you're probably going to hear about opioid and adrenal insufficiency in your board. I mean, that would be a very good question. I mean, that knowing about the knowledge of the participant in the exam. They had 102 patients, and these were from the pain management clinic, and this is the duration of the years, and they were on intermittent or continuous opioid at least for 90 days, so at least 3 months. So diagnosis of the opioid-induced adrenal was made in about 9% of the patient, so with a minimum intake of at least 3 months. And what they found, but these are important kind of a clinical pearls in this topic, is that none of the patients was taking less than 20 milligram morphine milligram equivalent had AI. So you can use that probably as your cutoff. Many patients who were on higher doses did not have AI, but you can use that 20 milligram morphine milligram equivalent as your cutoff for further evaluation. And they found that the cumulative exposure, and you multiply milligram by months, was the only predictor for the development of the AI after taking opioids. It was about 1,300 milligram versus 3,600 milligram. Another finding was that after stopping it, that 6 out of 7 patients recovered adrenal function. So most patients, after they stop the opioid, they are able to recover their access. You can find about different websites that give you the morphine equivalent milligrams. So you just put the name of the opioid that the patient take, and then you can calculate the total amount and then go from there. Question number 3, a 65-year-old African-American man with a long history of smoking has recently been diagnosed with lung cancer and has a 3 centimeter lipid poor right adrenal mass and is planning to undergo FNA of the adrenal tumor. Sometimes when a patient doesn't have any other evidence of a metastasis and there's a single nodule on the adrenal gland, which is lipid poor, then they may consider doing a biopsy because it will change the patient, becomes a stage 4 if the patient has metastasis. Past medical history is significant for hypertension. Electrolytes are normal. Blood pressure on the day of the exam was 115/80 millimeter mercury, and the pulse was 90. What is the best next course of action? Measure plasma metanephrines, CT-guided biopsy of the right adrenal mass, no need for FNA, proceed with right adrenalectomy, follow-up CT scan in 3 months to assess for any change in size, measure serum aldosterone and PRA levels, and if the ratio is more than 30, proceed with the ABS. You should get about at least above 95% answer this question correct. Very good. We have 91%. So, I mean, you just, that, I mean, although we all know about there are situations we come across the patient who did not have a workup for a pheochromocytoma before they have an adrenal nodule, then they want to have a biopsy done for like this cancer with cancer, or they want to have a procedure done. So that's important that we do the plasma or urinary metanephrines, and then if it's negative, as I mentioned, in this case, it may be considered. In rare cases, we can do biopsies when the patient management can change. What is the most likely diagnosis in the patient with adrenal insufficiency and the below exam findings? Postpartum hypophysitis, autoimmune polyglandular syndrome type 2, adrenal hypoplasia congenita, autoimmune polyglandular syndrome type 1, or adrenal leukodystrophy. Excellent, 81% got the answer correct. So candidiasis will not be the part of the autoimmune polyglandular type 2. So that is something to remember, and that they like to ask questions about this. So here we have the type 1 and type 2, and the main features is that it's usually happens in childhood. You have about 60% adrenal insufficiency, hypoparathyroidism happens about 90% of the patient, with chronic candidiasis another 75%. But in the type 2, you have adulthood diagnoses, and almost everyone have Addison disease. A large number have hypothyroidism, and about 50% type 1 diabetes. So that is important to make that distinction. Question number 5. A 19-year-old man presented to his PCP with fatigue, anorexia, and 15 pounds unexplained weight loss for the past 3 months. There is hyperpigmentation on the exam. His morning cortisol level is 1.2 microgram per deciliter, ACTH elevated, normal being about 5 to 60 picogram per ml. He has a negative adrenal antibody. He started on hydrocortisone and fludrocortisone, and with significant improvement in his symptoms. Which of the following is the best next course of action? Very long chain fatty acid panel, measure that, ACTH stimulation test, CT scan of the abdomen, fasting plasma renin activity and aldosterone levels, or measure the pro-opioid melanocortin level. Half of you got this answer correct. I mean, and that the question correct. And this is important, very important to let me go just briefly mention, but I'm going to slide. I mean, just get a slide about it. Some people mention CT scan of the abdomen. We're going to talk about when would be the indication for that. So the answer is A. So you need to remember, and this is the X-linked disease. So adrenoleukodystrophy and adrenomyeloneuropathy. There are usually three main phenotype of that. I'm going to ask you about that, but you can have mostly the cerebral one with the rapidly progressing. You can have a spine cord involvement with a lot of muscle involvement and with or without cerebral involvement. And about 8 to 10% of the patient can have only Addison disease. But the main important thing is that the initial manifestation can be about a third of the patient. So that's important. So when you see an adolescent, young adult man, you need to think about these diagnoses, because this can be the first initial manifestation about a third of the patient. And the women, they have milder disease, and usually adrenal insufficiency and cerebral involvement are rare. But the important thing is that the early diagnosis of the patient with the cerebral disease, they can have improvement in their outcome with the hematopoietic cell transplantation before they have this irreversible cerebral injury. So that's why it's important to measure that, and then if positive, the patient to be referred for further workup and treatment. Coming to the primary adrenal insufficiency workup, and this is from the figure from the Endo Society guideline in 2016. In infants, of course, you need to measure the 7-hydroxyprogesterone, and maybe selected adults. And for example, patient may have a non-classic CAH that may have some abnormal cortisol level. But in majority of what we deal as an adult patient, you can start with 21-hydroxylase antibody, and if that is negative, then you measure the in males, in men, you measure the very long chain fatty acid, and if that is negative, then the patient should have a one-time CT adrenal just to make sure that there is nothing else going on, like an infiltrative disease, bilateral process going on. So that would be the usual kind of imaging need, or the biochemical workup imaging in a patient with a primary adrenal insufficiency. But if they have a antibody positive, then you do not need to proceed further. Question number 6. A 70-year-old man was found to have a homogeneous 4 centimeter right adrenal mass on a CT study during the workup of the abdominal pain. The non-contrast CT attenuation value is 5 Hounsfield units. Which of the following statements is correct? Obtain an MRI of the abdomen to better characterize the adrenal mass to rule out metastases or ACC. Due to the size of the adrenal mass, it should be removed. The adrenal mass is benign. The adrenal tumor is low in fat content. Once FIO has been ruled out, if any of the mass needs to be done to rule out metastases. You will get a question about this topic of the non-contrast CT and imaging. That is very important. You may get actually several questions. So you need to be familiar with this topic. So please key in your answers. Okay, 70% answered correctly. And the question that, more than the 50% get the question correct, and you are the one that you could not correct it, maybe that's a topic you can read about it more. So the answer would be the C here. This patient has a Hounsfield unit of 5 units on the adrenal nodule, and that is consistent with the benign lesion. And this is 100%. I mean, of course, you don't want to measure the necrotic part or cystic part, but in a homogeneous mass less than 4 or 5 centimeters, this mass is not going to be cancer or metastasis. And these are 2 images that you can see, a lipid rich and a lipid poor, and you can measure these on your computer, I'm sure, in your institution, and calculate that. But radiologists almost always provide that information, or they should. We have shown, and others have shown also, this was the first study we did using the pathology as the gold standard, and every patient with a Hounsfield less than 10 on a non-contrast CT had either adrenal adenoma or hyperplasia. These are the myelolipomas, and these are some other groups, including FIO, metastases, ACCs, and some other conditions like schwannoma, lymphoma, etc. When it comes to adrenal size, it is important to look at the size. And of course, as the tumor grows more than 4, and especially more than 6 centimeters, the chance of malignancy increases. But I just want to show you that there is a significant heterogeneity. And I mean, metastases, they can be all over the place. Even we saw a patient with the ACC that they have been less than 3 centimeters. So the size is important, but it comes next when you look at the CT characteristic, MRI characteristic of the patient's imaging. Question number 7. A 45-year-old man was found to have a 3 centimeter left adrenal mass on the CT of the abdomen during the workup of the left flank pain. The non-contrast CT density of the mass was 25 Hounsfield units, so it was a lipid poor, more than 10. The patient denies any history of hypertension. Family history is not significant. Normal electrolytes on routine labs. Blood pressure is 115/70, and the heart is 78. So what is the next best course of action? CT of the abdomen 1 year to ensure stability, 1 milligram overnight dextropression test, PRA and aldosterone, plasmametonephrine's aldosterone, PRA, and 1 milligram dextropression test, CT-guided final aspiration, plasmametonephrine's, and 1 milligram overnight dextropression test. These are important questions that you should know for the board exam, how to work up a patient with adrenal incidentalomas. Good, 72% were correct, and the answer is the last one. I saw 22%. Yeah, the patient doesn't have any history of hypertension, and the blood pressure is normal. So there is, in the absence of hypertension and or hypokalemia, there is no need to measure aldo and PRA level in this patient. So in contrast to the Cushing syndrome workup that you have, you can use 2 out of the 3 of the screening tests, for example, the 1 milligram, the saliva test, and the urine-free cortisol. When it comes to the adrenal glands, adrenal nodules, the best test has been shown based on the associated with comorbidities, the development of adrenal insufficiency post-op, mortality, morbidity data. And now we have multiple studies, large ones. I mean, this one is about more than 1,000 patients with the, what we call the possible mild autonomous cortisol excess is a bit cortisol between 1.8 and 5, and more than 5 as a mild autonomous cortisol excess. The new terminology for these, based on the European guideline, is a max mild autonomous cortisol secretion, and used to be called as a subclinical Cushing syndrome. So now we have prospective, retrospective studies that's showing that there is increased mortality and morbidity in this patient. Here you have patient with a non-functioning, patient with a milder degree of abnormality, and patient with a more severe degree of abnormality. And you can see there was 1.5 and 1.7-fold increase mortality in those patients. And these people don't die from jumping from the roof. I mean, they die from cardiovascular disease, cancer, and infection. Question number 8. Which of the following adrenal tumors would be the best candidate for measurement of tumor washout characteristics? 4 centimeter mass with a drop in signal intensity from in phase to out of phase during T1 weighted MR images. 5 centimeter homogeneous mass with a non-contrast CT density of 5 Hounsfield unit. 4 centimeter lipid poor adrenal mass with a high clinical suspicion for pheochromocytoma. 7 centimeter mass with a non-contrast CT Hounsfield of -55, or a 3 centimeter mass with a non-contrast CT Hounsfield of 30. We have some split here. The majority got the 46%, about half of you got the correct. Then that would be the typical tumor. So you have a lipid poor adrenal mass, and that needs to be evaluated, can be evaluated further by the washout characteristic. About, I got the list of the, but I think some of you mentioned about the C and D. The D is a myelolipoma, so that is -55, anything less than -40. So that is a myelolipoma. The 4 centimeter lipid poor adrenal mass with a high clinical suspicion for FEO. But that is important to know. About 1/3 of the FEOs, this is extremely important, can have washout percentage that kind of overlap with the benign tumors. So they have a high washout. So that is a washout cannot be used to rule out pheochromocytoma. That is extremely important. Even sometimes we see radiologists make that mistake, and there is a tumor lipid pool with a 60%, 70% washout, and in the radiologists report them as adenoma. And the data is out there, multiple studies that these people, these patients can have up to 30% of them can have high washout. So how do we measure that? I mean, you don't need to measure it, but I mean, that's usually done by the radiologist. You can also put the numbers. You have the pre-contrast, 1 minute and 15 minutes, and then you can come up with a number. And this is the case, for example, with the pheochromocytoma, with the absolute washout of 72%, for example. Another important thing when it comes to imaging is that there have been a number of studies we have shown and others have also shown that when you have a homogeneous mass with a lipid rich, and this is a study and I put a few other ones that's showing the patient with the lipid contents, large number of the patient with the non-pheo and pheochromocytoma, and you can see that the chance of having a pheochromocytoma is extremely low, and the tumor is less than 2-3 centimeter. And these ones that were positive were about 10 Hounsfield unit. So extremely unlikely to have a tumor that lipid rich and be pheochromocytoma. So it is reasonable in a homogeneous mass that is lipid rich, you just omit the workup for pheochromocytoma because of the fact that you just need to deal with the false positive results, and there is not much finding in that. So that is also important, and this has been also brought up in multiple review articles about this topic. Number 9, a 40-year-old woman with a 3.5 centimeter lipid-rich adrenal mass has been referred for further evaluation. Which of the following about the mild autonomous cortisol secretion is correct? There is an increased prevalence of MAX among men. Patient with an ACTH level less than 10 should undergo 1 milligram dextropression test. Hyperlipidemia is the most commonly associated comorbidity in patients with MAX. No randomized clinical trial compared surgery versus conservative management in patients with MAX. A free cortisol level less than 0.08 microgram per deciliter during the 1 milligram dextropression test may be used as a normal response in women taking oral estrogen. We have a split here. Some of the questions are a bit harder than the others, but I think it's important to go over these. So what was about the answer? The correct answer is actually E, but there's some people answered the B and D. So you don't need to have a low ACTH level to do 1 milligram dextropression test. Some of these patients with abnormal 1 milligram dextropression do not have low side ACTH level. The ACTH can be between 10, 20, 25 picogram per ml. So that's not required to have a low ACTH to do a 1 milligram dextropression test. And actually, there is a randomized study, just going to briefly mention about that. In Italy was done that they look at the compared surgery versus conservative treatment. Okay, so this was done at Mayo Clinic. They have done some good studies, and this was done by Dr. Banco's group. 47 women on oral contraceptive, 66 women not on oral contraceptive, and 55 men. And they look at the free cortisol after 1 milligram dextropression test, and that this would be mostly useful in people who are taking estrogen. So the upper post dextropression test in men and women non on OCP was 0.05 microgram per deciliter, and in women was 0.079. So I made it 0.08 microgram deciliter. So you can use these cutoffs for evaluation of women who are taking estrogen. And there were also some clinical perils in this study, and one of them was, for example, that in about 75% of the women who were taking estrogen, their levels still were normal. So you can start with just measuring a total cortisol, and if it is abnormal, then you can go ahead and measure the free cortisol. So that is one important point. Another one was that all the patients who had a falsely elevated total cortisol because of being an estrogen had a level between 1.8 and 5. So if the level is more than 5 microgram per deciliter, that's likely not related just to estrogen. So again, you can use this as a clinical peril in your practice. This study by Morelli was published in 2022, and they had a large number of patients, but they ended up with the 25 patients who went to the surgical arm. These are random. This was a randomized study, and 30 patients with the conservative approach, which means that they just did a standard of practice for managing the blood pressure and blood glucose levels. And what they found was that they look at the worsening of the blood pressure, just these black columns, and then the improvement in the blood pressure, and they look at the worsening of the blood pressure, and there was significant difference between the two groups, both in improvement and the ones who had worsening. And when you look at the glycometabolic and glycemic control, there was a significant improvement in the patient who were surgically treated, but the difference in the people who had worsening of the glycemic control was not statistically significant. So there is now even a randomized study that looking at the blood pressure and the blood glucose. And as You may remember the blood pressure is the most important comorbidity associated with the mild autonomous cortisol secretion. Question number 10, which of the following statements about primary pigmented nodular adrenocortical disease is correct? Patients have a significant increase in ACTH after CRH stimulation. There is usually a rise in serum cortisol or 24-hour urine free cortisol following administration of dexamethasone. About 95% of patients with PPNAD have familial disease. Most patients present after the age of 50 years of old. There are bilateral multiple large adrenal nodules on the CT scan. Please answer your question. We have a split here. So actually the majority of the patients with the PPNA do not have multiple large adrenal nodules. So they have the adrenal nodule actually may look normal on the CT, or they have a small nodularity. So that will be happening in bilateral macronodular adrenal hyperplasia, not in PPNAD. Some people also answered the C, and that is not true actually. About 30 to 50% of the patients are familiar. About a half of these patients are sporadic. So the correct answer is B, and that's again important question to know about it. And most of these patients come at young age, less than 30, and about half of them before age 15 years of age. This was done at NIH. This is a Lidl test, the 6 days. So we have the baseline 0.5 milligram every 6 hours for 2 days, and you have 2 milligram every 6 hours for 2 days. And they compared the patient with the macronodular adrenal hyperplasia, patient adrenal nodule, single adenoma, and they look at the patient with the PPNAD. And these people have a significant increase in the urinary free cortisol. And you can see that also after 1 milligram or 2-day low dose dex suppression test. And that if in none of the, I mean, there was about 20% of the patient with single adenoma had some rise too, but none of the patient had an increase more than 100%. So that is sometimes when the patient, when the physician see these, they think that maybe there was some mix up by the lab, that they kind of mixed the samples, and that was not a correct labeling of the samples, but you need to keep in mind in this condition. Question number 11. A 75-year-old man with a 2.6 centimeter lipid put adrenal mass and a history of labile blood pressure has been referred for further evaluation. Plasma norepinephrine is 2.4 nanomole per liter. Your unit may be different in your lab, but you just think about the upper limit of normal. So this is about 2.5 times above the normal range. Metanephrine was in the normal range. Aldo 12 nanogram per deciliter. PRA was elevated or not low, not suppressed, 4.5 nanogram per ml per hour. Cortisol 0.8 microgram per deciliter after 1 milligram dexamethasone test. His current medication include amlodipine, lisinopril, amitriptyline, sertraline, metformin, and aspirin. What is the best next approach in managing this patient? Repeat resting plasma metanephrine after holding amitriptyline and sertraline for 3 to 7 days. Labs are not suggestive of underlying FeO. The patient should undergo the saline suppression test. Proceed with MIBG scan. Most false positive plasma and urinary metanephrines are related to the metanephrine fraction. Very good. 72% got the answer right, and some 14% mentioned that. I mean, you have a patient with a 2.5-fold increased norepinephrine. I mean, you can't say that labs not suggestive of underlying FeO. I mean, usually anything above 2-fold needs to be looked at, that evaluated, and of course, if it's more than 4-fold, usually that is, or 3 to 4-fold, that is FeO until proven otherwise. But I would say that I'm not comfortable here at this point to say that this patient doesn't have the FeO. And this has a lipid poor adrenal mass, and that is important, taking a couple of different blood pressure medications. So knowing about some of the drugs that interfere with the workup is important. But before I go over that, I just want to mention to you, and most of you looks like got it right, that the majority of the false positive are related to norepinephrine and normetanephrine as a metabolite. So this is a study we did. I want you to just focus on the group 3, which is the people without FeO. And this was a surgical pathology. So these are, and we use the surgical pathology as gold standard. So as you can see, we have the urine normetanephrine upper panel and the plasma normetanephrine, and we have the urine metanephrine and we have the plasma metanephrine. And you can look at the group 3. The majority of the false positive are related to normetanephrine. And we had very few actually none in the plasma, but we can also see some minor elevations. So if you have an elevated metanephrine fraction, you should look at the numbers much more carefully and repeat the levels after resting metanephrine, for example, that we do, and do not dismiss an elevated metanephrine fraction, although normetanephrine up to twofold usually is a false positive. So these are the things that need to think about that when you look at the metanephrine, normetanephrine fractions, including norepinephrine uptake inhibitors. Tricyclic antidepressants are a notorious one, but you can have a serotonin norepinephrine reuptake inhibitors, and norepinephrine dopamine reuptake inhibitors. So you can always, sometimes even if you don't remember, you can just look at the mechanism of action and find out if there is anything to do with the norepinephrine uptake. SSRI can also be associated up to fourfold elevation. Phenoxybenzamine, some stimulant, amphetamines, MAO inhibitors, withdrawals, including alcohol, for example, some of the atypical antipsychotics. When you go from age about 15 to about 60 years of age, the levels about almost doubles in normal people. So think about that, the levels would be less important and less significant, mild elevation in older age group. Exercise can increase the levels by about 30 to even fourfold elevation. So have the patient not to exercise that day. People will have higher levels in a sitting position. That's why we do sometimes resting metanephrines. Having uncontrolled comorbidities and of course renal insufficiency, again, that can raise the levels up to twofold when they have renal insufficiency. And there are some minor issues with the diet, high catecholamine diets like nuts and fruits and coffee and smoking, but usually these are not significant. I thought also putting a slide about false negative plasma metanephrine is important. That is, when you come to plasma, it's very unlikely. So almost always when you have a normal plasma metanephrine, you can clinically you can rule out the pheochromosome. But there are some rare situations, and these are in small tumors. In the early familial pheo, when the patient was had a genetic testing found and they have a microscopic disease, a small residual tumor after surgical resection, for example, early recurrences when the tumor is small. There's also dopamine secreting tumors, the 3-methoxytyramine available now, the urinary, at least in United States, that you can measure that in some of these, and you can measure the plasma catecholamine that will give you the dopamine, or urinary catecholamine that you can measure the dopamine levels. And also sometimes in patients with metastatic pheo, after you remove the original tumor, the metastases may not be biochemically active. So you need to keep that in mind also, that may happen. Question number 12. A 71-year-old woman with a history of hypertension and diabetes mellitus type 2 was found to have a 6.7 by 3.8 centimeter retroperitoneal mass during a workup of anemia. She had high levels of urinary normetanephrine, with the final pathology being consistent with the paraganglioma. 1 year later, her plasma normetanephrine levels started to rise after the initial surgery and found to have multiple abdominal and pelvic enhancing soft tissue nodules, most consistent with metastatic disease. And here are some of the lesions. You can see one here, you can see another one here, you can see here. So which of the following mutation is most likely to be present in her case? SDHD, VHL, SDHB, NF1, or RAT mutation? Excellent. So 78% got it right. So that is great. So this patient, I have seen numbers ranging from 20 to 70% can be associated with malignancy based on some different reports. And SDHD mostly happen in head and neck paragangliomas. The VHL and RAT mutations usually do not cause malignancy. Rare, the malignancy is them in rare, and the neurofibromatosis type 1 is about 10% of the patient we can see malignancy. So SDHB or SDH-bad, you can remember that. That is the most likely mutation in this patient. So sometimes also important to remember about the MEN2 and the cutaneous lichen amyloidosis. Usually happens as a very pruritic lesion, and between the vertebra and the scapula, you can see that, and you can have these brownish papilla in the skin. You may get a question in the board. A 22-year-old woman, question number 13, 22-year-old woman with a history of depression and seizure disorder, complains of fatigue, muscle weakness, and 40 pounds weight gain over 1 year. She's currently on famotidine, paroxetine, and phenytoin. Exam showed moon phase, supraclavicular fat patterns, few skin bruises. Which of the following is the best test to evaluate her for Cushing syndrome? 1 milligram dextropression test, 2-day combined low-dose dextropression test, followed by CRH stimulation test, overnight high-dose dextropression test, 24-hour urine-free cortisol, or a 2-day low-dose dextropression test. Okay, so 65% answered correctly. Remember here, the key is that just recognizing phenytoin in the list of medications. So there are medications that can induce the cytochrome P isoenzymes and can increase the clearance of dexamethasone. Rifampin, phenobarbital, phenytoin are kind of things to remember. So that is important to kind of recognize that they like these kind of questions to make sure that you pick that up. So anything that to do with dexamethasone would not be our favorite test to be done here. I did not put the saliva cortisol here. That can be done another option, but anything that to do with the dexamethasone would not be the first choice to go. And when you do give these people higher dose of dexamethasone, it still may not work. I have tried in some patients that work, but majority I increased the dose and still I got very low levels of dexamethasone. So I put this slide here. You can look at that later on. Remembering the CBG again, estrogen and the dextropression. We talk about that, the dex clearance. Remembering about the shift workers for late night salivary cortisol, the CKD in the urinary free cortisol measurement, especially when they have advanced CKD, can lower the level of cortisol in the urine. People who are drinking more than 5 liters can have increased urine free cortisol because of hyperinfiltration. And then we talk about shift workers, and improper collection can be with the late night salivary cortisol. So these are things to remember about that. Based on 2016 Endocrine Society guideline, in which of the following conditions further evaluation of primary aldosteronism was recommended compared to the previous guideline? Hypertension with the sleep apnea, adrenal mesentelomas, controlled hypertension on 2 agents, including a diuretic, hypertension associated with only spontaneous hypokalemia, sustained hypertension more than 135 or 85 millimeter mercury on 3 different days at 3 different times. Okay, the correct answer is A. No, not hypertension associated, can be with a spontaneous or diuretic induced hypokalemia. It doesn't need to be a spontaneous hypokalemia only. So let me just go over that. So that this was added compared to the previous one. And here you can see this is a paper from Endocrine Society guideline from 2016. And that's the hypertension with sleep apnea was added to the list of case detection for primary aldo. Sustained blood pressure more than 150 over 100 on 3 different days, 3 measurements. Resistant hypertension on 3 drugs, including diuretic, or on 4 drugs, more than 140 over 90. A spontaneous or diuretic-induced hypokalemia, hypertension in a patient with adrenal mesentelomas, not without hypertension. Family story of the early onset hypertension or CV at a young age, and first degree relative of the patient with the primary aldo. Number 15, a 64-year-old man has a history of resistant hypertension and hypokalemia. Current medication include lisinopril, amlodipine, and hydrochlorothiazide. The lab results include aldosterone 35 nanogram per ml, which is elevated. PRA is low, 0.15 nanogram per ml per hour. Potassium is low at 3.2. Which of the following is the best next course of action to confirm primary aldosterone in this patient? To the saline suppression test, 4-day salt loading test, stop all 3 antihypertensive medication, start verapamil, hydralazine, and doxazosine, and repeat the labs in 2 weeks. Obtain a CT scan of adrenal glands and proceed with the adrenal venous sampling, or do a captopril challenge test. 65% of you got the answer right. Again, important to pay attention to the question that more than 50% answer right, and you may not have get it right. So, you know, the saline suppression test, 4-day salt loading test, and cap-loop challenge test are reasonable tests to do. But in this case, you have an aldo which is elevated, more than 20. You have a PRA which is very low, and you have a history of hypokalemia, and the patient has a low potassium. So this patient doesn't need any confirmatory test. So there has been a number of studies has come up recently. These are from 2020, 2019, that showed that you can bypass the confirmatory test in a patient. And this is a picture from 2016 Endocrine Society guideline. And here at that time, they had 1+, but that 1+ now has increased. A patient with a hypokalemia, very low renin level. Usually, when I say low, I usually use a 0.6 nanogram per ml per hour as my cutoff, and a PAC more than 20. This patient, no need for confirmatory test, you can move on. It may not be safe to do confirmatory test in this patient and start to change the medication to the non-RAS modifying agents. I put this table for you that you can maybe look at as a reference later on. These are some of the medication that can affect the aldo and renin level. Remember, anything that we do to the aldo renin, the more effect is on the renin level. So I mean, if something is increasing the renin and aldo at the same time, the increase in renin is more. So for example, here, the beta blocker can lower the renin level, they increase the AR ratio. The aldo can be also lowered, but the decrease in the renin level is more. That's why the ratio goes up. The one that I have a little sign around them is that when they go in opposite direction. So when you have the patient on ACE inhibitor, ARBs, or dihydropyridine calcium channel blockers, you raise the renin, you do lower the aldo, so that significantly can lower the ARR. So this is something to keep in mind, and when you evaluate a patient on different medication. Question number 16. A 35-year-old woman has a history of severe hypertension. She had blood pressure spikes up to 210/115 millimeter mercury while taking 3 antihypertensive medication. Hypokalemia was resolved and blood pressure significantly improved after a start on spironolactone 100 milligram daily. Her recent lab results include aldosterone 45 nanogram per ml, PRA of 0.2 being low, aldo elevated. Potassium is now 4.1 on spironolactone. The CT showed bilateral small adrenal nodules. Which of the following is the best course of action to confirm the etiology of underlying primary aldo in this patient? Stop spironolactone for 6 weeks before proceeding with the AVS. Increase the spironolactone dose with the goal of raising PRA above 1. Change the spironolactone to eplerenone to raise the PRA level. Proceed with the saline suppression test, or proceed with the AVS. We have some split here. The correct answer is E here. Again, this is important from your day-to-day practice beside your board exam. Stopping spironolactone for 6 weeks before proceeding with the AVS. You know, gosh, this patient had a blood pressure of 210/115 on 3 antihypertensive medication. A bit young age, but I would say that right now, with the new data that we have available, this patient with these numbers does not need to have the MRA does not to be stopped, and you can move on with the lateralization. So now we can have certain population of our patient with a questionable PA that we don't need to do any confirmatory test when the aldo was elevated, PRA low, history of hypokalemia, and also people on MRA, neurocortical antagonists, when they have a low PRA level, you don't need to stop the medication. So here, again, I have listed a number of the studies that the outcome of AVS in patients who are taking neurocorticoid antagonists. I mean, nothing else in this patient can cause this. I mean, the PA, but the question is that it may not be safe that you stop the MRA and try to kind of to adjust the medication and more, especially in the older patient group. Question number 17. I passed some of these trying to make a brief explanation, but I'll be happy to answer during the QA if there are more questions about this. A 58-year-old woman with a 10-year history of hypertension has been referred to for endocrine consultation due to a lack of adequate blood pressure control on 3 antihypertensive medications: hydrochlorothiazide, lisinopril, amlodipine, and taking potassium. Blood pressure is 150/90, pulse is 87. Aldo is 16, PRA was 0.6, potassium 3.5. The Aldo PRA level ratio was 27. The 24-hour urine aldosterone was elevated with the appropriate sodium load, more than 200 millimole per day. Potassium was 80. Creatinine indicated a good sample size. And at the end of the test, Aldo was 12.9 and potassium was 3.1 at the end of the salt loading test. So the patient underwent AVS, and you have the AVS result here. And this was done with cosyntropin infusion. What is the most likely diagnosis? Left aldosterone secreting adrenal adenoma, bilateral idiopathic adrenal hyperplasia, right aldosterone secreting adrenal adenoma. Patient may have a left-sided adenoma or bilateral disease, or the aldosterone levels are not suggestive of primary aldo. So we have cortisol here, we have aldo, we have the low IVC or periphery, right adrenal and left adrenal veins. So 50% mentioned A. The correct answer actually is the D. And let me just go over that with you. So remember, we have the similar cortisol in the right adrenal gland and the low IVC or periphery here. And this was done with cosyntropin. At least you should have about 4-fold increase in cortisol. So the right was not catheterized. That's the one that has a 90-degree angle, and usually it's harder to get to it by especially the areas who are not experienced. So here we have only the selectivity index is positive for the left adrenal vein. So this patient had either left-sided adenoma or bilateral disease. Only appropriate left adrenal vein catheterization here. So you measure the left aldosterone cortisol is 9.5 and the low IVC is 2.5. The tumor may be on the left side or patient has bilateral disease. So I just changed the numbers here. So here we have the cortisol 358 in the right and the left is 445 here. So you look at the bilateral appropriate adrenal veins catheterization. The left aldosterone over cortisol is 9.5. The right one, the ratio of aldo over cortisol is 0.31. And the low IVC is 2.5. So the 9.5 over 0.31 is more than 4-fold. And this patient has a left aldosterone secreting adrenal adenoma. You can also look at the right one and compare it to the periphery, and you see there is significantly lower, less than 1 or less than 0.5. So that patient has a left-sided disease. Here you have only appropriate, again, selectivity index at the left side. And in these cases, the left aldo over cortisol ratio is 0.58, the periphery is 2.5. And now your ratio of the left side, the side that was only catheterized over the periphery, is less than 1 or less than 0.5. So in the one side that was catheterized, the ratio is low. So that suggests that probably the aldosterone secreting adrenal adenoma is on the other side. So that here is the right side. So that you can indirectly infer that most likely the disease is on the underside. So it is important that you look at the catheterization and you look at the combination of the lateral ratio and the contralateral ratio and what the ratios are. But if only one side properly catheterized, get the AC ratio in the adrenal vein over the AC in the low IVC. And if it's less than 0.5, adenoma is likely on the other side. And if it's more than 1, can be on the same side or bilateral. So as we had the case number 1 presented the numbers. If you have a low ratio on the side that has, compared to periphery, on the side that has been catheterized, that usually indicates that it is on the other side. And if you have a high ratio, it can be that side or can be bilateral. Now, people have also talked about other things. For example, if you have a ratio more than 5.5 in the left side, which is easier to get, you may have a 100% possibility values. I mean, some data has also been kind of published, helping the patient to be able to characterize when the AVS was non-optimally. So just wrap up the workup for the primary aldo. You start with the PRA and aldo. As you know, hypokalemia is absent in about 50 to 80% of these patients, so that lack of hypokalemia cannot be used as a sign of stopping the workup. correct hypokalemia, you can get a very low aldo levels. I have had patients with primary aldo, proven primary aldo. Aldo was down to 1 nanogram per deciliter when they had hypokalemia. We use a ratio more than 20 to 30, and an aldo above 7 I use. Most patients have a number more than 10 nanogram per deciliter, and the expert recommend a threshold for aldo of 5 to 10 nanogram per deciliter. I use the 7 because that's the cutoff I use during the saline suppression test to proceed further. And confirmatory test, I use one of these 3 tests. Saline suppression test is my favorite thing to do. It's easier and the patient is under my observation. And then we talk about that no need for confirmatory tests if the patient had an aldo elevated, low potassium and low PRA level. The saline suppression test to be done in sitting position, that's important. And then going with the CT of adrenal glands, adrenal gland sampling once the disease has been confirmed. No need to stop the MRA if PRA level is low. And whether to do the AVS with or without cosintropin is still a question in the air. We do it without cosintropin simultaneously, but there are proponents of doing it with or without. And of course, if you can do it both, that would be great. But radiologists don't like to spend a lot of time in the room with the patient and doing the test without and with cosintropin. Question number 18. A 19-year-old woman with ambiguous genitalia at birth had clitoroplasty during infancy. Non-compliant with her pediatric follow-up, seeing you to establish care. At age 8, start on amlodipine for hypertension and reports a history of hypokalemia. Her current regimen includes prednisone 2.5 milligram in the morning and 5 milligram at bedtime. However, there is a history of non-compliance with her medical therapy. So 9-year-old with a hypertension, and on exam, she has acne and hirsutism with a coarse voice and slightly muscular body habitus. Other medication include spironolactone, amlodipine, and the blood pressure is 143/92, the pulse of 65 during the clinic visit. Here are the numbers for the patient. The question is, what is the most likely diagnosis? We have elevated testosterone level in this woman. You have elevated ACTH, likely indicating that the patient is not taking the glucocorticoid regularly. 7-hydroxyprogesterone is not elevated. Aldo is low. PRA is low. Patient has a very high level of androstenedione. 11-deoxycortisol was elevated. And the patient has also elevated DHEAS level. And usually this is not elevated in the patient who are taking their glucocorticoid regularly. So what is the most likely diagnosis? Okay, 72% got it right. That's correct. Remember, when you have hypertension in a patient with a CAH, either you're going to have a 17-alpha-hydroxy deficiency or 11-beta-hydroxy deficiency. And the difference would be here, the androgen levels will be elevated and here will not be elevated. So this patient has hypertension, usually have history of hypokalemia and have elevated androgen levels. So this patient has 11-beta-hydroxylase deficiency. You will get questions about this without any doubt. So here you have, and this patient had also, they have elevated 11-deoxycorticosterone, that's why they have hypertension and hypokalemia. 11-deoxycortisol is elevated. And here when you have the blockage with 17-hydroxylase, also they get elevated deoxycorticosterone, but they do not have elevated androgen levels. Which of the following statements about patient with untreated CAH secondary to 17-alpha-hydroxylase deficiency is correct? The female patients are virilized. Patients are prone to adrenal crisis. They make up about 5% of patients with CAH. The secondary sexual characteristics are usually present. Aldosterone and PRA levels are low. We have significant split here. So remember, these females are not virilized because they have low androgen levels. So because of the fact that these patients having elevated deoxycorticosterone, while they can have adrenal crisis, they are not prone to them because you have high mineralocorticoid activity. It makes about less than 1% of the patient with CAH, not 5%, which is true usually for a patient with 11-beta hydroxy deficiency. The secondary sexual characteristics are usually not present because they have low androgen levels and estrogen levels, and then the patient have low aldo and PRA level, and the reason is that because they have elevated deoxycorticosterone, which cause increased fluid salt retention, and there will be volume overload causing hypertension, and they have a low aldo and PRA levels. So although you see that there is a blockage here and you may think about that the things are moving this way, but these people have low aldo and renin level. Question number 20. A 32-year-old woman has had baseline and post-cosintropin 70 hydroxyprogesterone levels of 367 and 1830 nanogram per deciliter. I put the numbers in different unit too. She has been trying to get pregnant for the past 2 years with a history of a miscarriage about 1 year ago. Which of the following statements about this patient is true? Despite elevated 17 hydroxyprogesterone level, she likely has underlying PCOS. She should undergo genetic testing for 21-hydroxy deficiency. The risk of having a child with classic CAH is about 1/80. Start dexamethasone 1 milligram at bedtime and continue through pregnancy. Start glucocorticoid therapy to achieve a progesterone level less than 0.6 nanogram per ml or 2 nanomole per liter during the luteal phase. Please answer the question. Yeah, I thought that you're gonna. Some of you may choose the E, and that is indicative of patient with classic CAH. Usually, such intense therapy is not necessary for patient with a non-classic CAH. So this patient has any levels above 1500 nanogram per deciliter. Some people have used 1000. I don't think they're going to quiz you on that, but this patient clearly has elevated level abnormal test, which is consistent with a non-classic CAH. Taking dexamethasone at bedtime is not a good idea for someone who is going to break pregnant. There are safer medication. It can cross the placenta. So usually we do not treat them with dexamethasone. Most of these patients do fine with it if they have a history of miscarriage with like a 15 and 5 milligram hydrocortisone or 10 and 5 milligram hydrocortisone, and they are at a very high rate of pregnancy. This patient should go under genetic testing for 21-hydroxy deficiency. That is very important. And I'm going to tell you why. It's an autosomal recessive disorder, of course, and there are two types of mutation. You have a classic and non-classic. Remember these, that a normal person has a classic or non-classic and a normal variant. So if you have one normal, you're going to be normal. If you have a classic and non-classic, you become non-classic. If you have a non-classic and non-classic, you become non-classic. And you have a classic and classic, become classic. So remember that when you think about the CAH genetics. So almost about 70% of the non-classic CAH are compound heterozygous. What does it mean? That they have a classic mutation. So without genotyping, these patients have about a 1/250 risk of having a child with classic CAH. So that's extremely important. Any patient with non-classic CAH should have a genetic testing done. I mean, if they can, because there is a risk of having a child with a classic CAH. And if a patient carries a classic CAH mutation, then the partner should be tested. If they don't have classic mutation, then you don't need to worry about it. But if they have a classic mutation, then the partner should be tested to see if they have a classic CAH mutation and have the genetic consult done. Measurement of 17-hydroxyprogesterone cannot replace genetic testing analysis, since it's not reliable to differentiate classic and non-classic CAH. So that's why the genetic testing is important to be done. A 34-year-old man with a history of non-compliance with his medical therapy has been referred for fertility evaluation. He has been trying to have children for the past 3 years without success. He has bilateral hard nodules during the testicular exam. These are the TARTs. Testosterone is 180 nanogram per deciliter, androstenedione 420 nanogram per deciliter, within the normal range. DHEAS is 25 microgram per deciliter. FSH is low, LH is low. He's currently on hydrocortisone 10, 5, and 5 milligram. Which of the following statements is correct? Refer the patient for bilateral partial orchiectomy to improve his chance of fertility. The sperm analysis and potential sperm banking are best done after better control of CAH. Change his glucocorticoid regimen to prednisone 2.5 milligram in the morning and 5 milligram at bedtime. An elevated FSH level after intensification of glucocorticoid is a good prognostic marker for his future fertility potential. Please Q answer. Let's see here. So the correct answer is C, and 60%. Yeah, so that's a good idea, but not waiting for better control. You should just do it right away. If you have any viable sperm, you should just bank it right away. So you don't want to lose time. So it is good idea. So you are correct in that, but you don't want to wait for a better control of CH and do that. I mean, if you're able to get any good sperm, you should bank it right away. But here you need to intensify the regimen, and usually in these patients, sometimes you need to do reverse glucocorticoid therapy to have a better control, because clearly you have a androstenedione, which is more than twice the testosterone, and that indicates poor control. Okay, let me see if I have any. So monitoring therapy for men in these patients. Remember, the ratio of androstenedione to testosterone is less than 1. Most normal people less than 0.5, and a value more than 2 indicate poor control, as it was the case. And remember that suppressed gonadotropin are a reliable sign of infertility in this patient that had a very low level. And if you control the patient and the FSH start to come up, that means that they probably had the damage from the TART, for example, in this patient, if the FSH start to come up. So that can be a poor prognostic factor for the having sustained testicular damage. Here we have a patient with the TART, that adrenal rest tumor that has been, after the therapy, has decreased in size, going from the right to the left to the right picture. Okay, I have maybe about a couple of minutes more, and I want to make sure I have a few questions about the ACC. I want to answer, discuss those questions. I think we should be okay. A 36-year-old woman was diagnosed with ACD-independent Cushing syndrome, and subsequently was found to have an 8-centimeter right adrenal mass. The PET-CT study showed uptake only in the right adrenal tumor, which was removed laparoscopically. The pathology was considered with adrenocortical carcinoma, weight score more than 5. Anything 3 or more is considered with the ACC. The Ki-67 staining was up to 30% in several hot spots. The chest, abdomen, pelvis CT study 2 months post-op did not show any abnormal finding except post-op changes in the surgical bed. Which of the following is the best next course of action? Repeat PET-CT study to find out if there are any new FDG uptake. Start pembrolizumab immune check inhibitor therapy every 6 weeks. Follow-up CT study every 6 months for the next 3 to 5 years, and then periodically after that, start the chemotherapy, cisplatin, doxorubicin, etoposide chemotherapy, usually called EDP. Start mitoten 1 gram daily and increase to 4 grams per day over the next 4 weeks. Excellent. 65% got it right, and then some people mentioned about 27% of you said that the answer would be the C. While the C is okay, and usually we do the follow-up imaging every 3 months for at least 2 years, and then we start to open that. But I mean, this patient had a hot spots of up to 30% Ki-67. So this patient at risk of recurrence, and the mitoten treatment would be indicated in this patient. So there was a publication this year about the Adjuvio 2 study, and this was for the mitoten in a patient with a low risk. And they had difficulty enrolling enough patients, but the study was stopped because of some poor enrollment. But the study did not show, based on what they had and the participation they had, that was a significant difference in mitoten versus no mitoten in patients with the low risk ACC. And they defined it as a indication for surgical mitoten based on having a resection margin which is positive. So if they don't know mitoten, if it was R0 or a stage more than a stage 3, and a Ki-67 more than 10%. So this patient had a Ki-67 of 30%, that would be indicated to have the treatment done, started on patient on mitoten. And majority of the patient, they usually have some of these criteria. So that I would say maybe about 10-20% of my patient would be not qualified for mitoten therapy. the prognosis was relatively good. And then another thing was that in the study, even the patient who did not take any mitotain, they did relatively well in the study. So at least at this point, the mitotain may not be indicated for this population. Which of the following about therapy with mitotain is correct? Primary hypothyroidism occurs in about half of the patients. There is a decrease in glucocorticoid clearance. The level of CBG is decreased. Benign ovarian cysts are frequent findings in women. The LDL cholesterol is usually decreased by about 50%. We have significant split here again. The level of CBG, corticosteroid binding globulin, is increased in this patient. That's why one of the reasons that you need to give this patient higher doses. And about 95% develop secondary hypothyroidism, not primary hypothyroidism. So that's something that you need to monitor closely and be aware of that. About up to 95% can have secondary hypothyroidism. And you can measure a free T4 at the beginning of the study and use that as a guideline for that. Having benign ovarian cysts are frequent finding in women, and usually you do not need to do anything about that, so that will avoid you to do anxiety for the patient and the extra workup for yourself. And the LDL cholesterol is and the total cholesterol usually significantly increase in patient taking mitotain, and sometimes based on their prognosis we may consider a statin therapy. Again, depends on how the prognosis is. Dr. Hussein, should I continue, or I think I need to stop now, or do I have a couple of minutes?
If you have a short case, we can do it. We're almost done with time, but if a short case is fine.
Maybe I'll do just one more case.
Okay.
And which of the following patient is most likely to have an impaired HPA axis? Prednisone 20 milligram daily in the morning for 2 weeks. Prednisone 10 milligram every other day for 1 month. Triamcinolone 40 milligram hip injection 4 and 12 months ago. Prednisone 2.5 milligram in the morning for 6 months. Fluticasone inhaler 500 microgram 3 times a day for 2 months in an HIV patient taking ritonavir. Okay, most of you got it right, 58%. Just going to maybe just about this question, a few slides, and then I'm going to stop and then answer any questions. So let's see here. So these are some of the practical guidelines about assessment of HPA axis. Any glucocorticoid dose less than 3 to 4 weeks, you don't need to worry about HPA axis suppression at the meaningful. I mean, I'm talking about clinical event. So a patient is given, let's say, a gram of solumedrol for 5 days, 6 days. I mean, I have not seen a report that this patient had an adrenal crisis. So in general, you can use these as your guideline. Any glucocorticoid dose for less than 3 to 4 weeks. No additional glucocorticoid is needed if patient takes morning doses less than 5 milligrams. So let's say take patient 2-3 milligram prednisone. Usually you don't need to do anything extra. They can just continue what they're taking. Patient on more than 20 milligram for more than a month should be assumed that they have adrenal insufficiency until proven otherwise, and then you should kind of treat them accordingly if they're going to have any surgery done. And people who are between 5 to 20 milligram prednisone for more than 4 weeks, then you may want to just check their access to see how they are, if they're planning to have any surgery done. So you can use these as some of your guidelines. The board like to ask this question, people taking azole derivatives like fluconazole, itraconazole, some of the HIV drug ritonavir, be aware of this interaction, that sometimes even the drugs like budesonide or fluticasone or like an injection of triamcinolone, these can have significant suppression of their HPA axis. So that is important. People who are looks Cushingoid, when they come to your clinic, be careful about that. Any patient looks Cushingoid, you should suspect that there is problem with the adrenal function. Doses less than 5 milligram taken in the evening at bedtime can cause HPA axis suppression. And also there are some rules that based on the literature review, and we had a relatively recent paper on these, that you should think about that, including fluticasone, which seems to be more potent than the other inhaler, more than 750 microgram daily. Some of the preparation come like a 250 microgram for 1 puff. 2 gram of per day high potency, and you can think about that one fingertip is about half a gram, and if they're taking more than 2 grams per day for more than 4 weeks, or if they have injections more than 3 in the last 6 months, you should think about AI in this patient. I always like to show these. Dr. Afandi published these. A patient who was on ophthalmic eye drop, different kind of getting different steroid eye drops for many years, had a very low cortisol level, and actually one was not taking it for a couple of days, the patient started not feeling well, and then had recovery, and as you can see, resolution of this pathological stria in this patient. We went through the 24 patient, and you have, I think, about another 7 or 8 that you can look at them. I'm happy to answer any question about those, and I would like maybe stop here, so making sure that we have enough time for Q&A. Thank you.
Thank you, Dr. Amir. That was outstanding review. Adrenal gland is one of the toughest glands we see in practice, but you made it sound very easy. Thank you. You covered most of the areas. We have questions, actually, several questions. Hopefully, we can finish them in the next 10 minutes, maybe. The first question is there a size of incidental adrenal tumor where you don't have to consider work up for co-secretion of cortisol or aldosterone?
So for the cortisol, no, there is no size cutoff. Any patient with the adrenal incidentoloma, and usually we call them as more than a centimeter. But I don't have any problem with the 8-9 millimeter that you can see discrete nodule. So all patients, regardless of the presence of the blood hypertension or any other comorbidities, they should have elevated with 1 milligram dextroproposin test. However, the patient who do not have hypertension or a history of hypokalemia, they do not need to be evaluated for the primary outcome.
Thank you. How about the use of 24 hours urine aldosterone? What's the role of using this test?
So the 24-hour urine aldosterone after the 4-day salt loading is one of the confirmatory tests. The aldo is more than 12 microgram per day, and then you have adequate salt loading. We usually measure that with more than 200 millimole sodium per day. So this is a very valid test. It has been one of the best that these tests and the saline suppression tests are the most two validated tests for this condition. However, in the case of, sometimes this question come up, what about if I do a baseline 24-hour urine aldo and it is not elevated? What happens is that we are looking to that. We're gathering some data about that. So I don't have any, don't want to give you any, I don't think that you have a board question about that. So the value of a basal without salt loading 24-hour urine aldosterone, but definitely after salt loading, and the people have done it between 3 to 5 days, it is one of the validated tests for the, although still there is some question about the mass spec and the aldo level, but that is a validated test until we get more information about the newer assay with the mass spec and what should be the best cutoff to differentiate.
Okay. The frequency of pheochromocytoma in patients with neurofibromatosis is 1, and should we screen everyone?
Yeah, so that happens in about, I have seen different reports of that. So about 5% of the patient that can have pheochromocytoma. That is what I recall from the most series. And that can be a number a little up and down based on that. About 10% of the patient who have pheo with the neurofibromatosis type 1, they can have malignancy. So that's higher than VHL and MEN2 patients. And yes, the patient who has hypertension, it would be very reasonable that to have them annually to do a plasma or urinary metanephrines and follow this patient.
Thank you. Interesting case of a young female with primary hyperaldo, doing very well in medical treatment with spironolactone, and she's planning pregnancy. How do you manage that?
Yeah, there are some diseases that actually may get better with the pregnancy. One of them, maybe Dr. Salvatore will talk about, is acromegaly, and one of them is a primary aldosteronism. Because of the high progesterone that compete with the aldosterone for neurocorticoid receptor, these people actually can get better during pregnancy. So maybe you want to just keep your patient pregnant all the time, if possible. But usually that is not of course, you don't want to use the the spironolactone in this patient. There are some case reports of using eplerenone in this population. But I would say that majority of the times, and these are not common, these are rare, but in these cases, there should not be a problem with the significant elevated blood pressure.
Yeah, I think you covered this, but quickly, monitoring CAH biochemically for males and females.
So the best biochemical marker that we have is androstenedione. I would say I always look at the 7-hydroxyprogesterone level 2, but that is seems to be a less important biochemical marker for following this patient. They can be over the place, but the androstenedione usually they seem to be the best marker, and our goal is to keep that in the either mildly elevated or upper normal range. That is our goal is. So as I mentioned in one of my slides, the goal is to get the ratio less than 1 of the testosterone over androstenedione for men. And so that is important. So making sure that majority of the testosterone come from the testicles, not the adrenal glands. For the women, of course, I would like to keep it in the at least upper normal range for most patients. I hope I answered the question.
Thank you. What is the cutoff for ACTH in clinical practice to use to differentiate ACTH dependent versus ectopic?
Yeah, so maybe I should answer this one. So if you have a patient with the ACTH level, and usually you may want to sometimes when the levels are borderline, get a few levels. Don't rely on just one value. And there are some problems with the Quest assay ACTH, Imulite assay, for example. You need to be sometimes send it to another lab, for example. But a level between less than 15, and again, normal being, let's say, 5 to 60 picogram per ml. A level less than 15, usually I'm comfortable being adrenal in etiology. A level between 15 to 25, I repeat the levels. I may sometimes, in some rare cases, in selected cases, I may do a vasopressin stimulation test because we don't have any CRH. And above the levels above 25, usually they are ACTH dependent. Now, the patient with ectopic, there can be some overlap between the Cushing disease and ectopic Cushing syndrome. But when you have a patient with the levels above 225, 250 picogram per ml, again, upper normal being about 60, in those cases, almost always you have an ectopic tumor. But the levels, the patient who have the levels in the upper normal range or elevated, but less than 225 picogram per ml, they can have a pituitary or ectopic etiology.
Thank you. What is the common practice in your clinic for patients who had pituitary apoplexy going for surgery? How do you cover them? And on discharge, how do you deal with their steroids?
Yeah, I wish Dr. Salvatore, I think, but maybe answer that question. but okay. No problem. So usually what we do is that, I mean, it sounds like a pituitary question, but happy to answer. So we give them high dose steroid for a presumed adrenal insufficiency because of apoplexy nature, and also to decrease the edema of the hemorrhage that they have usually in that area, and then that usually solve the problem. If they have visual field abnormality, we take them to surgery pretty soon. If they do not have visual field abnormality, we can watch them a little bit more and see how the steroid effect act, and then go from there. But we use high dose glucocorticoids, as I mentioned, for both presumed adrenal insufficiency and also to help with the edema related to hemorrhage, especially for the people who have a large mass and they may have some meningismus, severe headache.
Okay, I think we give them like 6 weeks after discharge and then bring them back to the clinic and evaluate them and see how they're doing. The last question was about the use of dexamethasone in TART.
Yeah, so just before I say that, the bringing the patient after 6 weeks is okay if they have apoplexy, if they don't have visual field abnormality. If they do have visual field abnormality, you need to take them to the OR and take the tumor out. So regarding the TART and dexamethasone, I don't like dexamethasone that much because it causes significant adverse events, especially long acting. So I like to use, when I want to use a bit longer acting medication than hydrocortisone, to use prednisolone or prednisone. And I may use a reverse glucocorticoid in a way that I give the higher dose in the bedtime and a smaller dose. For example, 2.5 milligram prednisone in the morning or prednisolone, and then 5 milligram prednisone at bedtime can be used. But in general, I mean, you can use dexamethasone too. It crosses the placenta, but in men, you can use that. And the goal is to suppress the ACTH level with the adequate dose. And these people can have regression of the TART after intensifying their regimen.
Thank you. I think we stop here. I think we're out of time. Again, you made it sound very easy, eloquently describing most of the cases that we deal in clinical practice for adrenal disorders. I'd like to thank you so much. I'd like to thank all the participants who are staying with us late until now. Tomorrow, inshallah, we'll start at 5 o'clock sharp with pituitary disorders. Dr. Roberto Salvatore will be with us, and the chairman will be Dr. Khalid Dahmani. This is the schedule for tomorrow. Inshallah, we'll start 5 p.m. sharp. Thank you all and have a good night.
Thank you.